Ladies and gentlemen, the forum will begin in 5 minutes. Please kindly silence your phones and feel free to borrow headsets outside for simultaneous interpretation. Thank you. 提醒各位贵宾，论坛再过5分钟之后即将正式开始。今天会议全程都有中英同步口译的服务，如果有需要中英同步口译服务的贵宾，都欢迎您凭证件到外面的服务台借取口译设备。也提醒您，等一下记得将手机转为震动或静音。非常谢谢您的配合。Ladies and gentlemen, we're going to begin in 2 minutes. Please take your seats. Thank you very much. 提醒各位贵宾，我们2分钟之后即将正式开始了，请您准备就座，谢谢。Ladies and gentlemen, good morning. Welcome to 2024 Global Health and Welfare Forum in Taiwan. 各位贵宾，大家早安，欢迎参加2024台湾全球健康福祉论坛。This year marks the 20th anniversary of the forum, and we are so very happy and thrilled to have been joined by so many experts and leaders in research, in policy, and in practice from all over the world for so many years. So firstly, we would like to take this opportunity to express our most sincere gratitude, appreciation, and thank you to all of you here. Without your continuous support and participation, there's no way we can come to where we are today. So everybody, let's give our friends and partners from all over the world a big round of applause. 我们先给来自于全世界的贵宾以及伙伴一个掌声哦，谢谢他们。20年来呢，一路陪伴台湾全球健康福祉论坛成长茁壮，参与许多重大议题的讨论。And now, to celebrate this very important and very happy moment, we'd like to bring out the traditional lion dance to the stage, all right? For auspiciousness, for prosperity, for good fortune, and most importantly, for good health to all of you, all right? 那接下来呢，我们就要掌声欢迎宋坤传译为我们带来的降狮献瑞。Give it up for the 宋坤 Performing Art Group， 掌声欢迎。Yes. Thank you very much to Song Kun, the Performing Art Group, and to celebrate the 20th anniversary of Global Health and Welfare Forum in Taiwan. 再次谢谢宋坤带来非常具有活力的开场演出哦。 那接下来呢，各位贵宾，首先呢，我们想先请摄影师到舞台上啊，帮今天参加论坛的所有的全场贵宾拍一张大合照。And now we'd like to firstly invite our photographers to the stage and take a photo of all of you here, our friends, our partners from home and abroad, for a group photo. All right, everybody. And we also got some props for our distinguished guests sitting in the front. All right, everybody, please look at the camera on the stage. All right. 好，我们请看向舞台上方大会摄影师的镜头哦。All right. Okay. 3, 2, 1. Okay, let's do one more. And can everybody thumbs up? Yeah. Oh, yes, thumbs up for more collaboration and cooperation and for more golden years to come in the future. 3, 2, 1. All right, thank you once again, and thank you so much for joining us this year. 再次谢谢各位贵宾呢，一同参与我们今年的台湾全球健康福祉论坛呢。那接下来呢，我们就要有请我们主办单位的贵宾上台致辞 ，Ladies and gentlemen. And next, we'd like to firstly welcome the Deputy Ministry of Health and Welfare, ROC Taiwan, Dr. Jingyi Lin, to the stage to give us the opening remark. 各位贵宾，接下来呢，我们就首先欢迎主办单位卫生福利部林静怡政务次长上台致欢迎词，让我们掌声欢迎次长。Please welcome Deputy Minister Lin.
Oops. Honorable Health Minister, Excellency, ambassadors and representatives, distinguished guests, our friends from around the world. Good morning.
Morning.
Welcome to the 2024 Global Health and Welfare Forum in Taiwan. This year marks the 20th anniversary of the forum. It's a great pleasure to host such a distinguished groups of health experts, policymakers, scholars, and professionals gathering here as a shared commitment to better global health and well-being. This year's forum is developing global health, the health right for all. This speaks to a fundamental truth. Health is a universal universal human right. It's a call to action. We must work cooperation across borders, sectors, and disciplines to ensure that no one is left behind. That all nations are included in international health framework, like the WHO, and that every person can lead a healthy life regardless of geographic locations or socio-economic status. In Taiwan, we have long believed that global health is a shared responsibility. Our commitment to global health diplomacy reflects this belief. We are progressing in this fashion through engaging in cooperation and dialogue all over the world. We are proud to welcome all of you today and trust all we could have important conversation on these issues. In 2023, average life expectancy in Taiwan was mostly around 79.84 years, while average health span was 72.43 years. It means around 10% of a person's life is spent in illness. This is a huge challenge for us. Additionally, it is estimated that Taiwan will become super-aged society by 2025. Yeah, next year, after 2 months. It means that healthcare and long-term care are our major challenge to our society. To ensure a health Taiwan, in August, we established the Health Taiwan Promotion Committee in our president's office. So far, we have proposed 3 major goals. First, promoting holistic and age-inclusive healthcare. Second, strengthening integrated medical care. And optimize work environment and fostering innovation. To achieve this goal, we drove 11 key action points, including health promotion, chronic disease prevention, increased cancer screening, and to transition between follow-up and long-term care, and as well as palliative care. We also will introduce the long-term care 3.0. It means we could connect chronic disease and health and hospital care and our long-term care. As well as we concerned about optimize children's health and addressing the mental health of all citizens, with particular attention to indigenous peoples. We hope to achieve comprehensive health care through our life course approach. As I close, I want to extend my deepest gratitude to our speakers and participants. It's a privilege to have so many renewed experts from Taiwan and all of your countries. Together to share their insight, experience, and innovative approaches. I am confident that over the next 2 days, our discussion will lead to significant progress in our shared missions of improving global health. I'm really looking forward to seeing how this event develops over the next 20 years. Thank you again for coming and to join this very important forum, and appreciate all your kindly sharing your experience. I hope all we could have productive and inspiring time. Thank you once again. Thank you.
Thank you very much to Deputy Minister Jingyu Lin. Deputy Minister, would you please remain on the stage? Yes, we're going to have a little celebration for the 20th anniversary of our forum. 那接下来我们请次长在台上留步哦。接下来我们有个庆祝仪式 and for that, we also like to welcome the co-organizer of the forum, and on behalf of the Ministry of Foreign Affairs, we'd like to welcome Deputy Minister Zhong Guangtian to the stage. 那接下来呢，我们也要有请我们论坛的共同主办单位外交部的田中光次长一起到台上来。Let's welcome him. 掌声欢迎。Yes, this indeed is a very important moment, and we're celebrating the 20th anniversary of the Global Health and Welfare Forum in Taiwan. So let's bring out the cake, okay? 我们特别准备了一个20周年的纪念蛋糕。All right. 等一下呢，我们就要请2位次长一起来切蛋糕哦，为这个我们的全球健康福祉论坛来庆生 ，OK? Yes, you can see the world and Taiwan on top of it, OK? And now the birthday cake and the birthday cake knife, all right? 我们请2位次长呢，先还不要切下去哦，等一下切最底层。切最底层就好了，然后我们等一下一起倒数，再一起下刀，好不好 ？OK? By the count of 3, I'm going to invite Deputy Minister Lin and Deputy Minister Tian to cut the cake, and let's celebrate this very, very happy moment. Okay? Are you ready? Let's count down. 3, 2, 1. Happy anniversary to Global Health and Welfare Forum in Taiwan. 好，2位次长，我们看向前方的镜头，一起合照一下。Yes, let's have a photo together. All right. Yes, happy birthday. Okay. One more, all right? 我们再拍一张。好，我们再次谢谢两位次长。Thank you so much to Deputy Minister Lin and Deputy Minister Tian. All right， 我们请两位次长在台上再留步一下下哦。接下来呢，我们要邀请今天真的说是有许多国内外的贵宾一同参与哦，所以我们请两位次长留步。接下来呢，我们要一起在台上来合照。我们请工作人员帮我们排一下椅子哦。我们请两位次长可以稍微在旁边一下下，让我们排一下椅子哦。Thank you very much. All right.In addition to the cake cutting, we would like to bring so many distinguished guests from home and abroad to join us on the stage for the group photo, all right? And also, just like Deputy Minister Lin just said, this forum really serves a very, very good forum and also platform for Taiwan to engage in conversation with our partners from all over the world so as to address different challenges facing us in the world. 好的，那接下来呢，我们事就先请两位次长到我们的中间来就座。And Deputy Minister Lin and Deputy Minister Tian, would you please take your seats on the stage? And next, I'm going to call out your names, and please join us in the front row, all right? Okay? Ladies and gentlemen, next we also like to welcome Saint Clair Prince, Minister of Health, Wellness and Environment, Saint Vincent and the Grenadines. 让我们掌声欢迎圣文森及格瑞纳丁卫生部长。Ota Kisino, Minister of Health and Human Services, Republic of the Marshall Islands. 掌声欢迎马绍尔群岛共和国卫生部长。And Kevin Bernard, Minister of Health and Wellness, Belize. 欢迎贝里斯卫生部长，掌声欢迎。Tuafafa Latasi, Minister of Health and Social Welfare, Tuvalu， 掌声欢迎图瓦鲁卫生部长。George Phil Bricknell, Minister of Public Health and Population, Republic of Haiti， 让我们掌声欢迎海地共和国卫生部长。Menduduzi Matsebula, Minister of Health, Kingdom of Eswatini. 让我们掌声欢迎史瓦蒂尼王国卫生部长。Aruna Stalky, former Minister of Health, Lithuania. 接下来让我们掌声欢迎立陶宛前卫生部长，掌声欢迎。Next, we'd like to welcome Santiago Adolfo Garcia de Stefano, Vice Minister of Public Health and Social Welfare, Paraguay. 让我们欢迎巴拉圭卫生部次长 Curtis Martin, the Permanent Secretary, Ministry of Health and Social Security, Federation of Saint Christopher and Nevis, 圣克里斯多福及尼维斯卫生部代理部长，掌声欢迎。And Boya Zhang, Chairperson of John Dong Foundation, 掌声欢迎董事基金会的张博雅董事长。Next we have Nirachiso Meko, Director of Bureau of Hospital and Clinical Services, Ministry of Health and Human Services, Republic of Palau, 帛琉卫生部医院及临床服务局的局长，掌声欢迎。Next, we'd like to welcome Yun Dong-woo, Ambassador at Large, Ministry of Foreign Affairs. 让我们掌声欢迎外交部吴运东吴任所大使。And Ketma Dor, Chairman of National Non-Communicable Diseases Commission, Saint Lucia, 圣露西亚国家非传染性疾病委员会的主席，掌声欢迎。Christian Ansorio, Advisor, Technical Advisory Team, Vice Ministry of Primary Healthcare, Republic of Guatemala, 瓜地马拉初级医疗照护次部顾问，掌声欢迎。Next, we'd like to welcome Jenda Liu, Deputy Minister, Ministry of Health and Welfare, 卫生福利部吕建德次长，掌声会有请。Mark Nellen, Director General, Family Affairs and Digital, Federal Ministry of Family Affairs, Senior Citizens, Women and Youth, Germany. 掌声有请德国联邦家庭事务、老年、妇女及青年部家庭暨数位署的署长。 And also today, we're very honored to be joined by 3 members of the Senate of Canada. Please welcome. 接下来呢，我们有请3位加拿大的参议员来到现场。Senator Marco Greenwood， 掌声有请。Senator Rebecca Patterson and Senator Stan Kutcher. 掌声欢迎. Please join us on the stage. All right, you may take your seats on the stage. Thank you very much. 我们请我们前排的贵宾可以就座喽，有请。All right. 那接下来呢，我们要请唱名到的这个贵宾呢，我们请站在这个后面。我们前方座椅的贵宾的后方 And now, we would like to invite our distinguished guests sitting on the second and the third row. Would you please all come join us on the stage? Yes? Okay? 那接下来我们工作人员协助引导一下我们坐在第2排跟第3排的贵宾哦，我们一起到台上来。We'd like to invite our distinguished guests sitting on the second and the third row. Would you please all come join us on the stage? All right? Yes. Okay, this way, everybody. Thank you so much. 那我们第2、3排呢，也做了许多来自于我们世界各个不同国家驻台的使节以及代表，今天呢，也都一起来参加今天的盛会。And next, we also like to welcome our distinguished speakers and moderators sitting on the 4th and also the 5th row. Would you please all join us on the stage for the group photo? All right. 接下来呢，我们有请坐在4、5排的我们这2天论坛的主持人以及主讲人，我们也一起到台上来，一起合照。Okay. All right, everybody. It's going to be a big one, so it's going to take some time. All right. Yeah, but we really appreciate this moment and. For us, this kind of group photo really is a token of friendship and also partnership. And thank you so much. All right. Okay. Just one tip for people standing in the back, make sure that you are not blocked by people standing in front of you, all right? 那我们可能要稍微调整一下哦。Professor Murthy, maybe you want to come to the front? I'm afraid that we couldn't see you sitting in the back there. 往前贴一点点。往前哦。Okay, maybe people, you may just a little bit up to the front a little bit. Just a little bit, okay? 我们稍微再往前一点点 okay? All right? 接下来呢，让我们摄影师稍微看一下，这样是不是大家都拍得进去 All right. Give us 30 seconds to make sure that we can see everybody in the photo, all right? There will be some adjustments and also fine-tuning to be done here, okay? 好的，一样我们也准备了这个手拿牌，要给前排的贵宾。如果有哪边有个贵宾会拍不到的话，我们马上帮忙移一下座位哦，都没关系。Okay? Yeah, we have like 50 people on the stage right now, and this is a big group photo. Yes, this year we are very happy to be joined by more than 40 distinguished guests from 17 countries. Okay? Okay, maybe we'll need you to maybe, it's okay, just to come to the front, it's okay, yeah. 我们这一次呢，总共有来自于全世界17个国家哦，有超过40位的这个贵宾一同来与会，那再加上国内的贵宾哦，一同来庆祝我们台湾全球健康福祉论坛20周年庆。Okay. Just bear with us for one more minute, okay? Just want to make sure that the photo is perfect with everybody and also the smile on your face, okay? 好，我们再稍微调整一下哦。All right? Yeah, also because we're going to bring out the photos, so wanted to make sure that we can see everybody in the photo, all right? Okay? Okay, just to make sure. That's just a test shot, okay, everybody? Yeah. All right? 这样 OK 吗？ Okay, our photographer is a perfectionist, yeah. 最后这边再微调一下就好了。那么这次2天的这个论坛呢，等一下就会有大会演讲的场次哦。那同时呢，还有3场的主场会议以及4场的平行论坛，探讨不同的这个主题。OK 了吗 ？All right? Okay. He said okay. All right. Everybody, let's have a photo together. Firstly, a very big smile. 3, 2, 1. All right? And the second one, you know what to do, right? Thumbs up, yes. You know it very well, Miss Murphy. Okay, look at our photographer. All right, 3, 2, 1. Okay, you want to make sure. So, all right, this is the moment of truth, everybody. We hope the photos are okay, okay? Yes, all right. 我们再给台上的国内外的贵宾一个掌声好吗？ Give them another big round of applause. Thank you so much. You may return to your seats. Thank you. Thank you so much, and we really appreciate your participation in this year's forum. 再次谢谢我们台上真的这么多的贵宾，大家可以看到我们台上贵宾合照的人数，就知道我们这一次呢20周年的论坛规模有多么的盛大哦。And also for the 2-day forums, we got a lot for you. Yes, after this, we're going to have the keynote talk session, and also we're going to have 3 plenary sessions as well as 4 parallel sessions. 那同时呢，我们这些不同的场次哦，也会聚焦各个不同重要的议题，像是全球卫生外交啦、数位卫生外交、国家级全球卫生策略。东亚国家如何应对少子女化的策略、青少年网络成瘾以及心理健康促进、欧美国家托育公共化的成效，以及数位医疗在缩短医疗不平等当中的角色等等哦。And we're going to cover a wide range of topics these 2 days, including global health diplomacy, health digiplomacy, national global health strategies, family policies to address low fertility of Eastern Asian countries, internet addiction and mental health promotion strategy, public child care policy of Western countries, and how to leverage digital health to reduce health inequality. All right. And now, everybody, it's time for us to move on to the keynote speeches. 那接下来呢是我们大会演讲的场次。And now, let me firstly bring your moderator to the stage to introduce our keynote speakers. 那接下来呢，我们首先大会演讲的场次哦，要邀请我们大会演讲场次的主持人到台上来为大家介绍主讲人。那我们再次谢谢次长今天莅临我们的开幕仪式。Thank you once again to Deputy Minister Lin for attending the opening ceremony of the forum. Thank you so much. Ladies and gentlemen, now please join me in welcoming your moderator for the keynote session, Professor Martin McKee, European Public Health, London School of Hygiene and Tropical Medicine, UK. 让我们掌声欢迎英国伦敦卫生及热带医学院欧洲公共卫生教授。Yes.
Okay. Well, thank you all very much. And I've lost track of the number of times that I've been to Taipei. I haven't been to every single forum because a pandemic got in the way, but I've been to pretty well all of them other than that. So it's great to be back in this wonderful country and to see so many old friends, just talking to my colleague, Dr. Ken Kuo, earlier, but I know many of you from my visits. So in this session, we will hear a series of speakers who will be sharing their wisdom on innovation and resilience. And as you've heard, it's my privilege to be your moderator. But before I introduce the speakers, maybe I could reflect a little bit on my own perspective, which is as someone who has been coming from abroad to visit Taiwan and to learn from Taiwan for many years. Now, in previous years, I've talked about the experience of the pandemic and the lessons from Europe, particularly the Pan-European Commission on Health and Sustainable Development, whose scientific advisory board I chaired. And in that, of course, we looked a lot at what was happening in East Asia. So, as we reflect on the lessons of the pandemic and we look towards a more resilient future, I think it's important to recognize that no country exemplifies the power of health innovation better than Taiwan. Now, as we all know, the COVID-19 pandemic exposed the vulnerabilities in health systems worldwide, challenging our understanding of what it means to be prepared. But Taiwan is a country that managed to control the initial waves of the virus with remarkable efficiency. And here we see a prime example of how healthcare innovation can fortify society, save lives, and inspire global change. Taiwan's response was no accident. It resulted from years of strategic investment, technological advancement, and policy foresight. From digital health solutions to data-driven contact tracing, Taiwan demonstrated the power of innovative thinking. And as we seek to navigate a post-pandemic world, Taiwan's example teaches us that health innovation is not just a tool, but is a foundation for resilience and progress. Now, one of the most impactful areas of innovation in Taiwan during the pandemic was digital health. Within days of the first cases of COVID-19, which of course were identified from Taiwan when they occurred in Wuhan, we should not forget that, Taiwan harnessed its advances in healthcare IT infrastructure to integrate travel history and health data, allowing frontline health workers to assess the COVID-19 risk in real time. By combining information from the National Health Insurance System, immigration records, and from the Epidemic Command Center, Taiwan created a centralized digital platform for tracking potential cases that sped up contact tracing efforts and helped authorities to contain the virus. Taiwan's National Health Insurance System allowed for the rapid deployment of telemedicine, a critical innovation during lockdown and social distancing. The system enabled patients to consult with healthcare professionals remotely, reducing the strain on hospitals and ensuring continuity of care. Now, this transition to digital healthcare wasn't just a temporary fix, it signaled a broader transformation in healthcare delivery that will serve Taiwan well for the years to come. Telemedicine, AI-assisted diagnostics and patient monitoring are poised to play a key role in Taiwan's health system moving forward, reshaping patient care for a more flexible and responsive future. Now, innovation thrives in ecosystems where the public and private sector work well together towards a common goal, and this is not the situation everywhere. But Taiwan's response to the pandemic has highlighted the importance of collaboration across sectors, particularly when time is of the essence. Early in the pandemic, Taiwan faced a shortage of face masks, and in response, the government collaborated with the private sector to increase production using real-time data to monitor and manage distribution effectively. This collaboration extended into technology development. Tech companies and government agencies work closely to create applications for contact tracing and exposure notification. Taiwan's electronic fence system used mobile phones to monitor quarantine compliance, notifying authorities of violations while maintaining civil liberties and privacy. Taiwan's approach to collaboration during the early phase is a model, I would argue, for other countries, and one that we certainly learnt from in Europe. Taiwan was one of the countries in East Asia that we featured in a paper in The Lancet that described the opportunities for learning from elsewhere. And Taiwan demonstrated its ability to respond with agility and efficiency, showing how collaboration is integral to health innovation. Now, I just want to say a few words about data before we get on to our speakers, because this played such a crucial role in Taiwan's pandemic response, and its importance really cannot be overstated. Transparent, data-driven decision-making characterized what was happening here, communicating the messages effectively, strategically, and anticipating outbreaks. Transparency was crucial for maintaining public trust, a critical factor in any health crisis, with daily updates, sharing data policy decisions through press briefings and social media, creating a sense of social solidarity, reducing disinformation, which has been the plague of our responses in so many countries, and increasing adherence to health measures. So here we can see in Taiwan a model that emphasizes that innovation is, of course, about developing new technologies, but also must be based on open communication with citizens. The pandemic clearly underscored the need, something we will be hearing about from the following speakers, the need for ongoing investment in innovation. And it's important to stress, and I speak as someone not from Taiwan, obviously, but who has been observing Taiwan closely. I can see how Taiwan's success was not coincidental. It was built on years of investment in healthcare infrastructure, research, and innovation. And recognizing that the next pandemic is not a matter of if, but when, I think it's reassuring for us all, wherever we are, to see how Taiwan has continued to invest in health-related research and development. Everything from AI-enhanced diagnostics to vaccines, antivirals, and so on. Taiwan has also invested a great deal in artificial intelligence and machine learning, techniques which, of course, have tremendous potential, although we should not get carried away. There are challenges there, something that we're writing about a lot elsewhere, particularly the need to build trust in that artificial intelligence, but that's for another day. But I think it's clear to those of us who visit Taiwan from time to time and observe it closely that you have set an example of preparedness and adaptability that is a guide for everywhere. But it's not just here. The impact of Taiwan's health innovations during the pandemic extended beyond its borders. You have inspired other countries to rethink their health strategies through knowledge sharing with the international community, exemplified by this forum, of which we're now in our 20th year. And this is an opportunity to demonstrate that health innovation has the power to drive global progress. Taiwan's contribution to global health is a reminder that innovation transcends national boundaries, and every country has a role to play in advancing healthcare for all. Now, Taiwan in particular has been a strong advocate for sharing technology and expertise to enhance global health security. We know that you face geopolitical challenges. We can see the challenges that you face, which have been, if anything, getting greater during the 20 years this forum has been taking place. But it's gratifying that Taiwan is continuing to share its valuable insights and resources. And this spirit of cooperation underscores the ethical dimension of health innovation, reminding us that advances in healthcare should benefit not only one nation, but the world. Now, I've said my role is to be moderator, and I've spoken far too long already. So it is, but I had to say something because I've come all the way from London to Taipei, and if I just stood up and read out a list of the names of the speakers, you would think, why did he come? So it's really just to say thank you to my hosts for inviting me and setting out why I think Taiwan, why it is always so interesting to come to Taiwan. But my role is to be moderator, so it's a great pleasure to welcome our first speaker, and that is someone who has a wealth of practical expertise in innovation for health. Dr. Osamu Kuni from Japan his biography is in the program. I'm not going to go through the biographies that are there in front of you. But I will invite him to share with us his experience, which I think is almost unique, of sitting at the top tables, trying to make sure that the world's leaders, and I use the world's leaders with a degree of apprehension, given what is happening in another country today. Let's just hope, fingers crossed, not thumbs up, but fingers crossed, that the world's leaders, first of all, that we have a world leader who believes in vaccines. That will be good. But to have world leaders who do not forget the scale and the nature of the last pandemic and work effectively to ensure that we are better prepared for the next one. Dr. Kuni, please.
Thank you very much, and the organizers for inviting me, and Mr. Chinsui, my friend. Thank you very much for inviting. Okay, so my talk today is a post-pandemic, what innovations are needed. Actually, I'm now CEO of Global Health Innovation Technology. Actually, my CEO is not the ordinary CEO, but my CEO is a Chief Entertainment Officer. Actually, I usually kind of entertain my staff to work hard for preparedness, and also kind of developing that products of vaccine, drugs, and diagnostics for infectious diseases. Okay, so as you know, this COVID-19 pandemic left a real kind of negative impact in the world, especially on health. Over 700 million people are, that are infected, and over 7 million people were killed, and also left the economic impact, especially this economic cost, even just to U.S. is just 14 trillion US dollar by the 2023, and also over 400 million full-time jobs were lost across the world. And as you know, the pandemic preparedness and response requires various elements and areas, including financing, governance, collaborative surveillance, access to countermeasures. Countermeasures are diagnostics, vaccine, and therapeutics, especially, and emergency coordination, community protection, and clinical care. And as you know, that we have 5 types of innovation. Innovation is not just only the devices, but of course mainly the products, including vaccines, diagnostic therapeutics, PPE, personal protective equipment, insecticide wearables, and the process. Even this innovation can facilitate process. So including surveillance, clinical trials, regulatory, manufacturing, and also market, especially awareness and demand creation of patients and the public, general public. And of course, supply chain, the rapid and efficient delivery of masks, drugs, and other essential commodities. And organizational, that innovation is there, that improving organizational efficiency, effectiveness, and facilitating innovation. So you might know that the G7 summit in UK in 2021 proposed 100 days mission. And that 100 days mission is quite ambitious plan, aimed to have a diagnostic test, therapeutics, vaccines within first 100 days of pandemic threat being identified. And this is the cumulative death due to COVID-19. And you can see that the day 336, the vaccine, quite effective and safe vaccine, was approved. Actually, this is extraordinary. We expect usually more than 10 years to develop this kind of vaccine. Actually, shortest one is 4 years. So we couldn't expect this safe and effective vaccine, developed within 1 year. But this time, this COVID really showed that such kind of extraordinary development. But if we shorten this time within 100 days, we could save maybe 98% of deaths. So how could this COVID-19 vaccines were developed within 1 year? Usually, as I said, that the shortest one is 4 years, but this time within 1 year. So they made a variety of innovative way of development. One is messenger RNA itself, quite innovation, right? And also the process, the innovation of process, especially this manufacturing development and scale up begins very immediately. And also phase 2 and phase 3 clinical trials cost consolidated. And there was emergency licensing, or that putting that the emergency use list. So approval process was also quite short. Actually, I was working in Global Fund in the past in Geneva, 9 years. At the time, because the Global Fund, as you might know, are fighting against HIV, TB, malaria. We really needed new products, new drugs, etc., because there are lots of resistance to HIV therapeutics, malaria, insecticide, etc. So we pushed the WHO for pre-qualification process. It takes sometimes 2 years, so long. So we pushed the WHO, we gave some budget and some human resources to shorten the time. But still, it takes more than 1 year, sometimes 2 years. But this time, FDA and other, that regulatory also try to make it kind of short, just using, kind of loading type of, the data, not kind of full set of data. Okay, so how to achieve this 100 days mission? Important one is preparedness. So in a pandemic time is very, very critical. Try to develop prototypes of priority pathogens and the framework, process, and have for rapid sample sharing is also needed. Formalize clinical trial network, collaborate registration process, and identify regional manufacturing hubs. So this kind of preparation is very, very critical. And once the pandemic starts, they need to leverage prototypes to develop and validate and test that safety and the efficacy. And accelerated the regulatory approval, of course, needed, and activate the regional manufacturing hubs. And even after that, the rolling out and the review is very critical for scaled the manufacturing, activated reliable pool mechanisms, evidence generation, global surveillance, and the centralized reporting, etc. Actually, there are a bit kind of different types of priority pathogens according to that different type of agencies. So these are kind of the mapping of target or priority pathogens. But currently, CEPI is the setting that the 25 virus families for as a kind of threats of a pandemic, future pandemic. And they developed a scorecard for this medical countermeasures for priority pathogens. This scorecard is very great because they show how much we need, so kind of finance, the target financing, and how much we have, current one, so it shows that kind of gap. And also what kind of pipelines there, that what kind of a product candidates for what kind of pathogens. So this is a really great, that a scorecard to show just at the glance. So COVID-19 has so many, the vaccine, therapeutics, and diagnostics. For diagnostics, already 88 products are there, even in this pipeline. And Ebola, there are some 17 types of diagnostics. And the vaccine and therapeutics is also there. But not others, so we need more kind of efforts. And as you know, it takes more than 10 years and sometimes more than 500 million US dollar, sometimes 1 billion for developing the vaccines and drugs. And especially to make the approved one approved drug, sometimes we need more than 20,000. Sometimes they say 700,000, screening of chemicals. So, and also it takes more than 10 years. That is why innovation is needed to speed up and improve the success rate and also decrease the price. And actually we have, even after the development, before development we call that it is Devil River. There is 3 barriers of developing medical countermeasures. One is Devil River, to move on to the development of some product, and Death Valley, before moving on to launching the product itself in the market. And Darwin Sea really hindered the expanding market. Okay? And actually this time, within 1 year, the vaccine was developed. But even after that, the access and delivery was quite difficult. And especially poor countries hardly access vaccines. So at the time of day 500, roughly half of the high-income countries got access to vaccine of COVID-19. But less than 1% of the low-income countries got access to this vaccine. That is why we really discuss very, very hard on this, equitable access. How to make, equitable access. Actually, I was working in UNICEF for 7 years in Myanmar and Somalia. So I worked quite hard and quite long years in Africa. So I know that, real hard to reach areas. So every day I was thinking about how to, reaching out to the really people in need in Africa. It is not only geographical, the hardness, but also the economic, difficulties, and sometimes civil war. Actually, the country where I worked is Somalia. So every day, kind of emergencies are, happening. Some of the civil war, some of the conflict, sometimes the outbreak of cholera, outbreak of the malaria, and a lot of infectious diseases, and sometimes drought. Some of the places flooding. So this global warming is really the affect even Africa and Somalia. So this last 1 mile is very hardest part to deliver. So I want to show some of the examples of innovation. I'm now actually in the past I was working in a field in Africa and other places, but nowadays moving toward the research and development of new products, because I felt innovation is really needed. Without new drugs, we cannot control and eliminate, especially TB, malaria, HIV, and many other that pathogens. So especially for surveillance and early detection, we really need to use more that advanced data analytical and AI. So use of big data, artificial intelligence to predict outbreaks, and real-time monitoring of social media search engine queries for early signs of disease spread, and genomic surveillance is nowadays gradually spreading the rapid sequencing of pathogens, and the global database for sharing genomic data. And the wearable technology is really important. Smart device that can detect early signs of infection through vital signs monitoring, integration of personal health data with the public health one. And diagnostic technologies, also very critical. Rapid testing, especially the point-of-care diagnostics test is very critical. As you know, PCR testing is quite easy to develop. Even within 1 month, we could make it. But the rapid testing, we are targeting not just within 100 days, but even 60 days after the pandemic may be possible, rapid testing. And the mobile diagnostic platforms, especially smartphone-based diagnostic tools, very critical, and portable PCR machines. Mpox, this monkeypox, Mpox. We already have a quite good PCR testing, but not rapid testing. So we are supporting that rapid diagnostic test for that one. AI-assisted diagnosis, of course, we need a machine learning algorithms to improve accuracy and spread of diagnosis, and also AI-powered image analysis for detecting infectious diseases. Well, actually, one of the Japanese company, Fujifilm, it has a very interesting kind of technology. Not good, AI technologies for imaging, but also using urine testing for the early detection of TB, tuberculosis. They use that. They repurposed their camera-related or film-related technology into healthcare. So very, very interesting. And for vaccine development, as you know, a messenger RNA vaccine technology is very important, but this is not only technology and the platform. So we are trying to use some other, even live attenuated one or inactivation of this vaccine also could be used for kind of as a new technology. And novel delivery methods, needle-free vaccine delivery system or thermostable vaccines. This time COVID vaccine, one of the vaccine required the cold chain under 70 Celsius, right? It's very, very difficult for Africa to, spread. Actually, when I was working in UNICEF, we tried to set up the cold chain, but many of the places, there is no refrigerators, very hot zone, over 50 degrees Celsius sometimes. So sometimes they have to carry the big vaccine box, putting that some of the freezing ones. So we really need thermostable vaccines. Smart vaccine distribution, blockchain technologies, AI optimizing distribution strategies. These are gradually, that applied in this world. Okay, there is, DCT called the decentralized clinical trials. So even clinical trials could be, using that innovation. Actually, in this COVID-19 vaccine development, over 800 clinical trials were conducted in the world. But actually, only 10% or even less than 10% of them were beyond that kind of the standard of quality, quality assured, and also quite not good design. So we really need a much better quality, but at the same time, some different type of decentralized clinical trials using virtual, remote, that kind of accessibility. So by using digital technologies and telemedicine and other decentralized process, we could increase the patient access and diversity, improve that patient experience and data quality and cost efficiency as well. And also treatment innovations. There are monoclonal, the antibody genetic profiles, personalized medicine, AI-driven screening of existing drugs for new application, and the combination and CRISPR-based therapies and etc. we have. And prevention and control measures, smart PPE, personal protective equipment, and UV light disinfection, air filtration, and digital contact tracing. The variety of innovation even for prevention. And One Health approach, meaning combining human, animal, and environmental health data, and also the control. So we could use the innovation for this one. Actually, One Health approach is not the new one, but application and operationalization was not so easy. That is why we really need innovation for that. And public health communication, of course, as you know that this time that it is not only the pandemic, but infodemic was spreading. So we really need to use this good AI-powered chat box or virtual reality training, etc., for that better communication and the training, etc. Okay, so pandemic is not only a threat. There are a lot of others, HIV, TB, malaria still, that infect more than 200 million cases and also killing 2.5 million. And antimicrobial resistance, as you know, it is kind of silent pandemic. And neglected tropical disease actually infect more than 10 billion people, quite chronic, and also giving so much kind of the lot of kind of issues. And climate change really increased the resurgence and the emergence of infections. Okay, actually I was involved in a G7 Hiroshima summit. Actually, that at the time, former Health Minister Takemi asked us to establish the G7 Hiroshima Global Health Task Force. And I was appointed as a 100 Days Mission Working Group. So we had a quite robust consultation with WHO, CEPI, and global actors. And we stressed the synergy between pandemic prevention, preparedness, and response, and other infectious disease control. And universal, stressing kind of universal health coverage and the system strengthening. Okay, so now we have a lot of organization and global health initiative to promote innovation. As you know, this CEPI is quite important leading agencies for vaccine development. FIND is also quite important for diagnostic development. READY, this is in the US, the kind of initiative for drug development. And ACT Accelerator. When I was working in a global fund, I was involved in this, ACT accelerators, access to COVID-19 tools accelerator for promoting access and delivery. So these are quite important mechanisms. And as you know, BARDA, SCARDA, HERA, these are kind of a financing and also, that operationalizing that agencies spending over $1 billion US, SCARDA, the 400 billion. So these are very critical. Okay, this is the last slide. So way forward, we really need to accelerate innovations. But at the same time, we need to look at the kind of global picture and global landscape. So we really need to look at the ecosystem as a whole, not just only innovation for vaccine, innovation for surveillance. Of course, each elements are very, very critical, but we really need to look at the whole picture and the whole ecosystem. Otherwise, this ecosystem could not work, right? So moving beyond organizational or sectoral, the boundaries to innovate for broader ecosystems and the common goal, and collaborating with diverse stakeholders, not only health, but also other kind of areas of sectors, collaboration is very much needed. Thank you very much.
Have heard we are living in very exciting times, and in particular, I think with the advances in artificial intelligence, a little plug, we published a paper on artificial intelligence in pandemics about a week ago. Just Google my name and that, and you'll find it in PubMed. And the applications are extremely wide-ranging. And I think this is a challenge to us in the health sector because there were remarkable achievements during the pandemic, as we've just heard. But there's a danger that we sort of give up a little bit or we just go slow. And if we look at what is happening with the developments in warfare at present, drone warfare, the use of artificial intelligence there, which we can discuss the morality and the ethics of all of that. But there's a danger that we get left behind in the health field. So I think that has been a very inspiring presentation to encourage us to keep up the momentum. So it's a great pleasure to welcome our next speaker, Joseph Savada, who is well known to this forum, has spoken a number of times in the past. And Joseph will be talking to us about values like equity and justice. And as he will tell us, and as we recognized in the Pan-European Commission, this is not an optional extra. It's not just the right thing to do to be equitable and fair, but it's absolutely essential in a crisis, particularly one involving pandemic and epidemic diseases. Because if you have not eradicated the microorganism in everyone, you have not eradicated it at all. And we saw, certainly in the country that I live in, how when we thought we were getting things under control, there were little islands within the country of multiple deprivation, where the virus was continuing to spread and just waiting for that opportunity to burst out again when we lifted our defenses. So, Joseph, you will be talking to us about, and we must get your title, Seizing the Window of Opportunity, Advancing Resilience and Equitable Health Systems Through Values, Innovation and Human Rights. Please, where are you? No, there you are. And I should say we were together in Copenhagen only last week, so we must stop meeting like this.
Thank you very much, dear honorable ministers, dear colleagues, friends, and it's my really great pleasure to be here today with you again and to share something from the wisdom of all of you. So this will be nothing new for you, just we will sum up together where we are and what the windows of opportunity for all of us could be, probably. So my topic is having the linkage to the nowadays very diverse world with many multiple emergencies and challenges. And this is also a way how we can tackle it and rethink, revise, very probably re-edit and re-establish our health systems, not to be anymore so vulnerable, but to be more resilient. So we can try to deep dive together. And this is the window which I will use during the presentation. These are my disclosures, and I am very grateful to Ministry of Health of Taiwan for invitation and covering my costs. So last year, if you can remember, we discussed together about research and rethinking research related to the global health. So I will just continue with this lecture, and I will bring up what we discussed at the end of last year's discussion together. And this is the window of opportunity. When we have the research, when we have the ideas, when we have the confirmation about the context and what is needed, so we have to really understand how we can apply it successfully. So this is the window. And window, it's something one usually looks through. We're looking out or looking in. And windows create a separation between here and there. And also, it's at the same time transparent. And the transparency brings us to nowadays and even to the future. So windows could really bring different perspectives. What we can see nowadays in our world. So we can see really huge challenges in different fields, from the climate change, from COVID, which has been mentioned by Dr. Cooney from the previous presentation, from the successes, but also failures, from need to invest, from need to understand, from fear to anxiety, uncertainty about the safety, about the peace, about health access and the equity. With numerous of the challenges, we are here looking through the window. And we can really use the analogy about the global health challenges and opportunities as, for example, to think about renovating a building, historical building, which is really almost falling down from outside. We can not only bring like new facade, something what is really looking nice, but also we can together to reconstruct it and to conserve it for future generations. And this is our main goal for the responsibility and being responsible for future generations, how we can cope with challenges nowadays. When we are discussing the resilience, so we have to define it. What do you understand under resilience yourself? It is very probably understanding which is bringing us at the beginning of the cycle, and this is the crisis. Each kind of crisis is leading us either through the resistance or through transient dysfunction of the system, either ourselves when there are personal crises, or the systematic when it's related to the national or regional or global health. And it could bring us to resilience or to promote more and higher and deeper vulnerability, which is related also to deterioration and multiplying crises. Great anticipation and also tool to cope with it in health systems is universal health coverage. Communities have resilience. We sometimes forget as a policymakers to use the communities because they have voice, but also power and also wisdom. They have needs and they have also ability to introduce best practices when we help them, when we empower them. And this is our common interest. And adaptive capacities, there are different theories behind. I am not going to bother you with. But we have to really accept that even traditional and even religion-based and other cultural insights are key either for disinformation and myth or for success, how to cope with challenges and how to be more resilient. And this is bringing us to the definition of resilience. And it means that it is ability to anticipate, to adapt, and recover to any challenges. When we are speaking about the equity, so we are often thinking perhaps about the runners and two different ways. Yeah. One line is very clean, well organized, without any obstacles on the road, and runners are running without any difficulties for the prize. But then we have parallelly other runners who are having really hardless, different obstacles on the road, and they need to overcome them. They can experience injury, crisis, and they can even give up. And this is how we have to understand different vulnerable groups, because they are affected usually the most in any kind of crisis. And this is our global responsibility to bring the equity as the right. When we are speaking about the values in healthcare, very often we are coming to a huge list of different values. Which are the most important? It's hardly to say, but I will use the analogy with IKEA. But I will use healthcare area, H-A-K-A, manual. What do we need to bring together to really stand it, to really last it, to be sustainable and to functional? Without some of those pieces, it will be just imagination. Oh, I would like to develop my new house, or I would like to construct my bed, which I ordered. I would like to deliver that and this duty or service to my patients. but I am not able because I'm missing this piece, that piece. Or I forgot my plan and I don't know how to put it together. So this is perhaps the responsibility for all of us and also our patients to create the core values and to remind ourselves every day about the safety and about the core principles, where we are, whether we are only the providers who are managing something for profit, or we are bringing values because it was the main intention why we started to work in health many years ago. So when we are coping with change, we can really think about innovation as a driver of change. It was mentioned in introductory speech of Professor Martin McKee. And it's very clear and obvious that there are just a couple of examples. And we know that window behind is really open and we have many, many, many opportunities, all of us. We just need to accept that there is no there is no resistance. There has to be always movement. And movement means innovation, because we reevaluate, we rethink, we reinvestigate, and we try to implement. So we have a couple of great studies recently published related to mHealth. And this is just one of the examples how it should be and it could be used and how it is interlinked with the health and with different sectors. Mamma mia, who can really be aware how to use it in the real life. So sometimes it is the same as we use the analogy with very old 99 sedan. The engine is very probably working, but if we would like to improve and we can use the same amount of fuel and we can drive a little bit faster or longer and deliver better care, so we need really to develop self-driving healthcare. And this is possible with limited and always lowering numbers of health professionals only with using innovations in healthcare. And there are some examples. When we are speaking about human rights, sometimes it's very silly, these kind of questions. Does really human rights belong to healthcare? It is really human right, equity, and blah, blah. It's like question, do we need a water, clean water for life? If we are still alive, very probably we need it. And it's the same with human rights. We need them and we need to accept that health is a human right for all. So, we cannot implement anything by our own. If each of us will be entitled to lead our communities or ministries or universities or private or public health facility, we will very probably influence a couple of people, but we will not make significant change. So multilateral cooperation is only the key to bring together, to speak together, and to really collaborate, to understand what the differences are, but differences are not against the change, against the movement, against the cooperation. We can have different ideas about plastic forks or wooden forks or no forks, just using hands, how to eat the dinner around the table. But we know that there is global table. There are funds, as it was mentioned, they are opportunities, they are human resources, but we need to combine them in a very wise way. All the policies are linked to the social determinants of health. And social epidemiology is something what is describing not only health systems, but also political decisions and political and cultural determinants of health, which are affecting us indirectly or directly on the individual level, or then as the society on the institutional or population level. And we know how to combine it with mHealth. A lot of research is done, but who can really understand it? How to implement challenges in really innovation. So sometimes we can think about challenges implementing innovations as this castle. You have Wi-Fi, it's proved by evidence that it is the best way how to connect, how to link together, how to access the most accurate and up-to-date informations. But then if you bring Wi-Fi to the castle with very thin walls, and it did not go through, and you expected, okay, I would like to have access to this and that, but there is no infrastructure settled for that. So it's very difficult. You see also very unequal distribution of the Wi-Fi coverage to the different population on the picture. And also privacy data. There are some people still hanging the paper because they are afraid to share anything because they cannot be ensured that system is not misusing their data. So this is our common understanding of the challenges. But we have many successful stories, but also, as it was mentioned in previous lecture, also challenges with unequal distribution of beta vaccines, diagnostic tools related to the pandemics. And it's similar when we are having the rows and we are swimming alone, or we are rowing alone, or we are rowing in the part of the group of just very, very locally linked and locally sticked to the consequences and context group. For example, like this, we are cycling because we don't have the direction, we don't have good wind, we don't have the leadership. But when we are bringing different actors together from different countries, different regions, different experiences, and we have really someone who knows how to lead and to set the priorities, we are able to use multilateralism for our common good. So, altogether, this was the substance to understand what the window of opportunity is. So what is it? To use right momentum for right implementation. Sometimes we have political momentum for a very short period of time. Average life expectancy of the ministers are different in each country, aren't? In my country, it is 18 months. 18 months. What you can do within this short period of time recently. So we have to really wisely think when is the right time and to bring right people together, to set the priorities and then to implement. This is window of the opportunity. And we have proof in many, many studies, either how to use the systematic opportunities for right investment decisions. Because even budget is limited, and nowadays we are thinking twice. We use not only magnificence glass, but also electronic microscope, how to really divide the budget appropriately. Yeah? We are thinking, rethinking, we are fighting between Ministry of Health and Ministry of Finance. But we have the proof that if you really focus on system and you would like to change at least something what will be meaningful as the core value for the next crisis, for resilience or more resilient development of the system, it would really benefit for your society, even with small investment, but definitely it is right time. So there are different windows of opportunities nowadays where we are facing human resources. So we know that it's really crucial to know how human resources are limited, but also to understand that there are different options how we can use them. Professionals, for example, anesthesiologists who are working every day in anesthesia when they are retired. There is no need let them to go to the retirement. You can use them in the faculties, in the universities, to let them teach, to help LMICs or other unserved regions to really improve their human resources or to develop the new, and so on and so on. So we have many examples. This is just the reflection about the challenges which we need to address when we are speaking about the opportunity. And this is the list which we came up when we started to work on systematic review regarding to this topic, but we did not finish yet, so I will share it perhaps next year with you or in the publication. So these are some of the key principles which we evaluated, and due to the constraint of time, I will go further. So health is a political choice, how to bring and develop solidarity, science, and making solutions to come from fragmentation to the integration. As Dr. Tedros used to say, we need to fix the roof before the rain comes. Are we doing this? So our vision for the future is really to set policy reform, to collaborate, and to understand what the needs are, to prevent polycrisis and to decrease polycrisis to metacrisis, because we know that it's not possible to prevent crisis at all. So these are basic principles. And last two slides, if you allow me, just brief takeaways. So window of opportunity, one of the window of opportunity is acting with urgency. Sometimes we need to recognize that there is really a right time, and if we don't implement something, there will remain the risk and the barriers for the future, and it will be more vulnerable system. And the second window of opportunity is expanding our imagination. Don't be afraid to dream, because people, they need leaders. They need to understand that someone is really caring. And we also need to understand how to inspire a new generation, coming generation, to take over our responsibilities. And I'm very glad that here are young people who are helping us to make a bridge, not to remain in the struggling and losing the values and the lives, but how to empower resilience and how to really look through the window of opportunity to the future. So congratulations to everyone. Thank you, Taiwan, for bringing us together again and allowing us to discuss burning issues, but also to improve our strength and partnership. Thank you.
Thank you very much indeed, Joseph, and thank you for also sharing the use of artificial intelligence and generating so many of your images. I could recognize ChatGPT, and I think we see the challenges there, the opportunities. It makes great pictures, but it hasn't quite got the spelling right yet. So, and that really raises this issue of trust and artificial intelligence. I'll do another plug. We've just published a systematic review on trust and AI, and also a book on trust in healthcare. You can Google it and find it there. You talked about the short life expectancy of ministers, and of course you have had elections recently, but I look more at Bulgaria, who's now just had its 6th election, general election, since 2021. And is likely to have another. So some countries are in this sort of endless carousel. So it's a great pleasure to introduce our next speaker, who is Arūnas Dulkis, who is a former health minister of Lithuania. Lithuania, small country in the Baltic state, but has played a disproportionate role in the geopolitics of this region that some of you here in Taiwan will be familiar with. I'll leave it at that. And interesting in the geopolitical scene. But Arūnas is particularly welcome, I think, because he comes, apart from being as a former Minister of Health, but from banking. And I had the great privilege on the Pan-European Commission to work with a number of people from banking and finance. Jim O'Neill, Lord O'Neill, formerly of Goldman Sachs, the inventor of the concept of the BRICS, Sylvie Goulard from the Banque de France. And I think when you look at what people from that background have contributed and their insights, often it's remarkable. And one individual I will pick out, because there are Canadians in the audience, Mark Carney, former governor of the Bank of Canada and the Bank of England, who has written a book called Values, topical for our present session, with the S and the values in brackets, which is, if anything, a public health textbook. So I would highly recommend that as a book that sets out some vision of the future of the world. So, Arunas, I'm particularly glad that you will be able to share your perspective coming from this combination of finance and from health. And where are you now? Please. Yeah.
Thank you, Martin. Okay, let's try to use this space. I'm not from banking sector at the moment, but yeah, it was a fact in my life. And Joseph, in Lithuania, ministers in average for a health minister is 18 months too. Average. I spent 42 months. Maybe because before that I worked as Auditor General. Who knows? Okay, we see. Okay, so many equipment what we need. Okay, Daja, Zhou, and good morning, everyone, ladies and gentlemen, esteemed colleagues and friends of Taiwan. Okay, I have come to you with good wishes, bringing health and harmony to our days. And I'd not say merely to please you, but because since 2020, Taiwan and Lithuania have been writing a remarkable new chapter in our relationship, one built on the shared values, resilience, and deep commitment to humanity's collective well-being. A pivotal moment came in November 2021 with the opening of Taiwanese representative office in Lithuania, not a Taipei office, but a Taiwanese office. Yes, this is the first office in Europe to have Taiwan in its name. This was not just a political milestone, but a powerful symbol of friendship, solidarity, and the recognition that Taiwan is a vital player on the global stage. As we gather today, humanity is faced with an urgent question. How do we build resilient futures? The COVID-19 pandemic has taught us many lessons, the most important of which is that humans, though often irrational, must find the strength to rethink our systems and embrace new ways of working together. In this context, we must turn out our attention to health diplomacy. The idea that global health security can only be achieved through international collaboration, trust, and shared responsibility. Before the First World War, scientists argued that wars would no longer happen because trade and economic ties has strengthened our nations to such an extent that war seemed impossible. Unfortunately, this belief was followed by two of the most brutal mass slaughters in history. People overlooked the fact that what truly binds them is not trade, but shared values. It also became evident that the human value of responsibility is still undeveloped. The Spanish flu ravaged Europe in a century ago, claiming more lives than the First World War, yet human memory is short. We soon forget lethal combination of pandemics and wars, which often work hand in hand. Today, war and disease once again threaten our global stability. And the toll they take on our health systems is devastating. The pandemic has exposed severe weaknesses in healthcare systems worldwide, from overworked and appreciated health workers to a lack of essential data and information needed to manage crises effectively. The global health infrastructure has been pushed to its limits. At the same time, wars across the world are causing humanitarian crises with healthcare systems unable to cope. We must not let history to repeat itself. We must respond with action, collaboration, and most importantly, hope. Taiwan has long demonstrated the resilience and preparation are not just goals but ongoing processes. Every day, planes fly over the island of Taiwan, and ships sail past Taiwan's shores every day. Every day brings intimidating maneuvers, raising the uneasy question, is today the day or will it pass without incident? I'm deeply impressed by how Taiwan has prepared itself for future crises, both psychologically and physically. According to Constance Wang, the head of Taiwan Representative Office in Lithuania, Taiwan is maintaining calm on the surface like a duck, but paddling intensely beneath the water. This balance of vigilance and resilience is something we can learn all. Taiwan understands that health emergencies, whether caused by pandemics, natural diseases, disasters, or war, do not respect borders or nationalities. This is where health diplomacy becomes essential. We cannot stop at national solutions. Today's challenges demand a global response. Health diplomacy requires collaborative governance, a form of governance where decisions are made together, resources are shared, and responsibility is collective. It's about forming international partnerships that transcend politics, geography, and differences in culture. Together we can overcome the most complex and large-scale crises of our time. In Taiwan, you understand this deeply. Your people's resilience, preparedness for crisis, and commitment to international cooperation are shining examples of what is possible when a nation invests in its future. We in Lithuania are proud to stand beside you, working together to build a world where health diplomacy is at the forefront of global security. The theme of Health for Peace, Peace for Health, championed by the World Health Organization, reflects the deep interconnectedness of these two ideals. But where there is war, healthcare systems collapse. We see this clearly in Ukraine. Russia's unprovoked aggression has not only caused immense loss of life and displacement, but it has also triggered a massive health and humanitarian crisis. More than 2,000 attacks have been carried out against healthcare facilities in Ukraine, targeting hospitals, ambulances, and medical workers with cruel cynicism. This is not just an attack on a sovereign nation. It is an assault on the fundamental human right to health. About 40% of Ukrainian families have at least one family member with chronic illness, but now they have problems accessing treatment. 40% of Ukrainian territory is mined, and we know that many more will lose their limbs, requiring intensive medical care, rehabilitation, and psychological support. The war has created a generation of trauma. 10% of the Ukrainian population will bear this burden. But the people of Ukraine, much like the people of Taiwan, are resilient. They cannot get tired, and neither can we. If the aggressors believe by pressuring our health systems, they can destabilize our societies, they are wrong. We will never tire of helping Ukraine, just as we will never tire of advocating for Taiwan's rightful place in global health forums. Yet, it is deeply troubling that Russia, the aggressor in this brutal war, remains a member of the WHO, while peaceful Taiwan, despite its exemplary contributions to global health, sits outside the door. This exclusion is not just a diplomatic oversight. It raises serious doubts about our global commitment to the principle health for all. What is WHO's role? How does WHO carry out its role in times of war? During the war, it is practically impossible to ensure human rights. War gives rise to outbursts of hatred and violence. Sexual violence reaches insane heights. All diseases worsen. Early diagnosis and prevention programs are disrupted. War creates mental health problems and destroys the opportunities to address them. War depletes healthcare resources and funding sources. Despite this, in the first month of the war in Ukraine, the WHO not only failed to condemn the aggressor Russia in its official statements, but didn't even dare to mention Russia by name, referring to the full-scale aggression not as a war, but as a conflict or simply a crisis. Why the leaders of the 194 organization wasn't criticizing the aggressor country by name. WHO officials are trying to explain that they are not politicians, that they are just healthcare organization. Russia still is a member of WHO Executive Board, which is responsible for WHO priorities. But Russia's targeted destruction of health facilities is in direct opposition to the WHO mandate of protecting health. Where is the logic is being silent? The sign discredits the WHO as protector of global health. This stain will remain forever on the pages of WHO history. 88 countries in May 2022 took a leadership in saving the WHO face. 88 WHO members adopted a resolution condemning Russia's attacks in Ukraine and opened the door to withdrawing Russia's voting rights in all global health formats. This resolution is not about politicization. This resolution is about the fundamental human values, human virtues, and the duty to hold the aggressor country accountable. Taiwan's continued exclusion from World Health Assembly is not just unfair, it is a lost opportunity. As Lithuania and many other nations have voiced, Taiwan's participation in global health security would only strengthen our collective capacity to respond to crises. Taiwan's medical innovations and health diplomacy are examples for the world to follow. Taiwan can help is not just a slogan, it is a fact. In November 2023, Lithuania and Taiwan signed a Memorandum of Understanding on Cooperation in the Health Sector, solidifying a partnership based on trust, shared values, and commitment to improve healthcare. The cities of Bucha and Borodenka in Ukraine, destroyed by Russia, will be rebuilt using an interactive three-dimensional platform to assess war-damaged cities and model their reconstruction. It is equally funded by Lithuania and Taiwan. Our collaboration stands as a model for others. But we know that medical partnerships offer more than just aid. They offer the chance to do more. Our efforts must focus on the two key areas: refining our methods of evaluating and monitoring health system preparedness, and creating platforms where nations can share their experiences and strategies. Imagine a centralized network where countries like Taiwan, Lithuania, and Ukraine can exchange their best practices for managing crises. In these dark hours, international solidarity becomes our most potent weapon. In the face of crisis, whether caused by war, disease, or natural disasters, our strength comes from our ability to act as one global community. As we look to the future, we must take this lesson to heart. Health diplomacy is not just about responding to crises. It's about building a resilient, peaceful future for all. In our increasingly interconnected world, health diplomacy has become a cornerstone of global security. It is not merely a negotiation between nations about policies and agreements, but rather it's about building relationships, trust, and shared commitments. Health diplomacy reminds us that partnership is friendship, and like friendship, it requires understanding and patience. To form a stable and long-lasting partnership, you need to have diplomatic skills. What is the secret of successful health diplomacy? What is the secret of successful in politics, diplomacy? In politics, diplomacy, and international communication, one of our characteristics is exceptionally important. What is this feature? I won't say yet, but I will tell you about this characteristic from my own experience. I would like to share a personal story to highlight this point. Once upon a time, the year 2022, the first month of the war in Ukraine, I visited Kiev Children's Hospital with my friend, Minister of Health of Ukraine. It was one of the first visits of foreign ministers in Kiev. We tried to visit as many wards as possible. What is most important for a child when they are in hospital? Of course, we had Lithuanian chocolate, we had tablets for children. One little boy named Dimachka hugged the gift so much that he got special attention from the TV reporters. In the next ward, I met a young man. The rocket injured his leg, but he spoke so inspiringly that the faces of everyone present smiled. The young man's unreal sense of humor made both patients and us laugh. When saying goodbye, I asked him about food in the hospital. And the young man invited me to visit him after the war in Chernihiv. He said, "I cook it very tasty." Okay, I said, "I promise, I will come." We exchanged phone numbers. He said, "Just call me Tolanchik." Please imagine, I can sense how it might have looked from the side. Cameras in the ward, flashing cameras. As often we say, that is just public relations. After returning home to Vilnius one day, I dialed his number. At first, just after answering, he snapped, and after minutes of silence, he recovered. He says, "I can't believe you called." I said, "Listen, we agreed, I promised you," and our communication became regular. It turned out that in 2023, I would go to Kiev again. We both wanted to see each other again, and we succeeded. After the hospital, Talanchik returned to the army, but the Ministry of Health of Ukraine took care of the permission for him to come to the meeting with me. Talanchik was allowed to meet and go to Kiev with his girlfriend. And then the first surprise appeared. It turns out that Anastasia, his hot friend, was hit by the same rocket and was also in the hospital during my last visit, just in another ward. Apparently, I also visited it. And this is not the end of the story. Another exciting surprise awaited me. It was difficult to hold back tears. You remember I mentioned at the beginning about the boy who got huge attention in the local TV reports during last year's visit. Anastasia says, and now I am sending the wishes from Dimachka. He is my little brother. Couldn't be together today. He started his first grade in September. By the way, the tablet still works. I was extremely excited at that moment. This story for me was like a gift of life, but aren't there too many coincidences? Please imagine, we saw so many people in one of the biggest hospitals in Kiev. It seems that invisible hand brought us all together in one story. But I believe it was not a coincidence, not some invisible hand that gave us this story. I think now you understand which feature I had in my mind when I ask you what is most important in politics, diplomacy, and interpersonal communication. I believe that for politicians, for us, the people, it is just important to keep our promise. Always keep our promise. The essence of successful diplomacy is trust and the ability to keep promises. Whether we are forming international partnerships or working to strengthen global health systems, the most important quality we must bring to the table is the ability to follow through our commitments. Taiwan and Lithuania are united by this very principle. Both our countries have demonstrated a high level of morality and trust. Taiwan, a place known for its deep sense of community and family, has a saying, Jia Ha Wan Shi Xing. Harmony at home brings prosperity in all things. This wisdom applies not just to our personal lives, but also to international relations. Global health is in many ways like a family effort, requiring us to work together with commitment to one another's well-being. Ladies and gentlemen, esteemed colleagues and friend of Taiwan, I have come to you with good wishes. Trutajia Shentii Jiankan Wan Shirui. I and my family wish everyone good health and may all your wishes come true. I do not say this merely to please you, but because my 3 daughters saw me off my home, me and my wife want them to live happily. Shishi. Thank you.
Well, thank you, Arunas, for an inspirational talk and for a reminder that we live in extremely worrying times. Those of us who live in Europe cannot ignore the lessons of history, and many of us are looking back at the 1930s as a prelude to what is going on at the minute. And also, I think that we're now in Asia, but we should recall that the events of those days had implications that went far beyond Europe. And of course, we now see troops from an Asian country on the front line in the Russian reinvasion of Ukraine. So as we look ahead to the days and weeks ahead, I think this is a salutary warning to us all that in a global community, we are all involved and we cannot avoid it wherever we are. So thank you very much indeed for that truly inspirational reflection, which I think means a lot for those of us like you. Many of us, I think a lot of people in the audience have worked in war zones, in my case, in the Caucasus and the former Yugoslavia, and a reflection of the reality that we have faced and we could be facing again. So with that, can I move on to our final speaker of this session? And this gives me a tremendous personal pleasure, Bettina, to invite Bettina Borish to talk to us about the health right for all within human rights. Bettina is, like myself, a long-standing attendee at this forum. We were both privileged to receive an award from the government of Taiwan a few years ago, so thank you very much for that. And also, I'd just like to say that normally I fly into Taipei and I fly out again, but last year Bettina and I and Shuti Chu, who was our host for the occasion, took us to see Sun Moon Lake and to see some of the clinics and hospitals around the country, and it was absolutely fantastic. And if you don't get a chance to see the rest of Taiwan when you're visiting now, it took me, I think, about 20 years to get outside Taipei. But, you know, if you get a chance, Shuti is a fantastic travel guide, but also it is definitely worth a trip. Bettina, please.
Thank you. Thank you, Martin, for the introduction. Thank you, ministers, and thank you, all friends in Taiwan. It is like coming home. When I arrive here, I feel really good. And Martin explained why. I start to feel Taiwan like my second home. Thanks to you all. Thank you. And I'm definitely deeply moved by the previous talk. I think there were all things that we have to think of and embrace of all of us. And when I saw the title of this year's forum, I saw the part Health Right for All, and Joves Suvada has already talked about human rights. And I thought, let us consider the link again that we all mentioned between human rights and health. So we know that just after the Second World War, due to the help and empowerment of Eleanor Roosevelt, the UN Declaration of Human Rights came to life. And we probably know the words all by heart. It says human rights are universal rights for all human beings, regardless of race, color, sex, language, religion, political or other opinion, national or social origin, property, birth, or status. This sounds to us, and I think in this room here, we all embrace it. But perhaps you know that already at that time, when the drafting of the UN Declaration went on, there were different views on these common rights. There were especially different views on one side and the other side of the world that later became into a really separated world that we called Cold War. One part, the first generation of rights, is the political and civil rights of every citizen, the basic rights of a person to live its life at home in justice. A second part of the rights, the so-called second generation, are the socio-economic, cultural rights, the rights to proper living that will give you a healthy life, to a proper work and proper work conditions, social security, education, and the special rights of women, very dear to my heart. That was the second part. And we have to put into our minds that already at the drafting, there was the situation that some of the most socialist Soviet Union governments never accepted the notion of natural political rights as signed in the UN documents, while the United States signed but never ratified the legal instrument designed to implement the social economic rights. So there was already, let's say, a spectrum. Now comes health into that spectrum. And here you see Dr. Tedros address the Health Assembly. We know that in the UN Declaration, the right to health and other health-related human rights, legally binding, is there. And at the same time, we know that already in the constitution of WHO, the right to attain his best status of health was a fundamental right of each person. So the link between the document UN and the document of the both are also close in timeline. You see that here in 48 we had the UN Declaration of Rights, and already earlier in the WHO Constitution it was claimed that health is a human right. So not only were they linked by time, but probably also by topic. And this was again underlined later on by the Convent on the Economic, Social and Cultural Rights, the ECOSOC, that clearly said it's not only medical care, but also the social determinants of health that are a human right. Well, we see that the right to health is indivisible from the other rights of participation, of food, work, but also political rights. It can only be taken as one. You will never be healthy without all the other human rights. What do researchers do? We all are in an academic background. Are they interested in this relation, health and rights, human rights? Yes, they are. They publish. This is out of a review that had looked at the publications from 1990 to now 22 and looked what was in the literature. And yes, you see there is a lot of publication, but mainly from the public health sector, less from the rights, the human rights side. And interestingly, here mostly topics such as accountability, participation are studied. And if we look at the other principles in this review paper, you see that, again, the topics of accountability, quality, acceptability in healthcare systems is very much looked at, but very little is done about the legal aspects, national strategies, legal mandates, collective efforts in legal context. So there seems to be a little bit of a split between those who look for human rights and those who look for health. At least they don't see it as a whole. Well, I showed you the timeline, the 40s long ago. But let us think back into the 80s. Into the 80s, so the human rights and both declarations kind of say it's together, but it's state theory. And in the 80s, something happened that really moved rights of people for health in the streets. Do some of you remember that in the 80s, young men died of diseases nobody knew? Young men died of diseases nobody understood, of Kaposi sarcoma and infections in the lung that nobody had ever seen. Well, these people went out in the streets. This was the beginning of the AIDS pandemic. And young men, mainly homosexual men, said, no stigma. We are not to be stigmatized. We need rights to health. We need proper treatment. What you see here, this is called a die-in. They went out in the streets and met not a sit-in, but a die-in. So they called for their rights to health. They even went to the big scientific congresses where we usually sit and talk to each other, to us without any problem. They came and said, please, do research for our disease. We need more research. We are dying now. So I think this was a point in time where WHO, this time the Director General was Afton Mahler from Denmark, clearly took a step further to put human rights to the rights side, not to the right side, rights side. Human rights in the AIDS pandemic. It was, I think, the beginning of the modern health human rights movement. People claiming their rights. And they were against the stigma and the discriminatory criminalization that they had to undergo. WHO came to embrace this indivisible link between public health and human rights. They had to see it together and to act together. So the WHO Global Program on AIDS shaped a right-based framework for global health. We thought we had a problem solved with AIDS. We don't have it. What do we have today? And we heard so well from Lithuania and Kiev and other places. We are more challenged than ever today. We have so many challenges that we could list them, and we do list them again and again. Between climate change, I really think that the armed conflicts, we have seen the pictures. We have, as of today, more than 100 armed conflicts going on in this world, between countries and inside countries. And we have, as also a consequences of both climate change and armed conflict, a lot of people migrating. Never ever have been so many people migrating in this world. And this creates for sure divisions also in the head of people. And it is in stark contrast to the Universal Declaration of Common Humanity. And again, even in rich countries, I see now financial constraints. They lived through the pandemic, and the next thing, they cut the public health budget. You know, this is really happening in places where the money could be spent for health and for collaboration with other countries. And we unfortunately see with migrations, with everything, that there's a lot of stigma, that there is exclusion, and that gender norms treating women is not going better in this world, it's going for worse. And all these are attacks on human rights and health at the same time. So it has been mentioned, geopolitics. I think that global health and geopolitics are now as well as seen together, as we have heard. There is this interplay between global health and geopolitics that even academia now looks at. And there are dynamics and shifts, and let's have a look at that. In today's global politics, there is a weird mixture of our classical multilateral UN system still there, with the question marks that we heard in the previous talk. How can it that Russia is there and decides on women's health, whereas Taiwan is not there in the WHO? We have, but in addition, a lot of non-state actors of different sizes and different importance that play and shift the global multilateral system. And some of them are like think tanks, others are visible, more visible. Some of them are just too rich single men. And There are resource wars, and we will see more of them. We will see resource wars around water, for example. And there are identity conflicts where we can question. There's disinformation, there's rivalry, and the shift of power. And I think we should think about how power shifts just in front of our eyes. I think especially of the BRICS countries. We heard about G7 from our colleague from Japan. We saw a picture from G7. Yes, these countries are mainly North American, European, and Japan, G7, and we have the BRICS that first started with Brazil, Russia, India, and China, but then in 24 added up 4 other countries. And I put them in this list intentionally because I would call the countries Brazil, South Africa, and India having a democratic kind of system, even if no democracy resembles the other, but I would call them democratic. And I dare to say that Russia, China, Iran, Egypt, UAE, and Ethiopia have more autocratic systems. UAE is a monarchy, it's a kind of autocracy. So we have a shift also between systems. We see that now people claim what is the best system. I am convinced, even if it's the most difficult one, we quote someone, that democracy is still the best one, but it's not all over the place. People in the pandemic explained to me, look at China, this is how it should go. One man decides and everything functions. Well, we have seen it didn't function so well, but this is what I call the war between systems and the shifting between systems. So geopolitics and right to health in times like ours, people like to talk about crisis. I always say the Greek word for crisis, as it is the old coming from Greek, means decision. So we are in times where we have to decide where we stand and what we want. And I think we have to address the power systems and the power shifts. We have to say that we need more collaboration than just competing. We have to address knowledge imbalances. We have to decolonize our knowledge and have it everywhere and around the world and pick up knowledge that we haven't used and we still do not use, such as indigenous knowledge or other people's, women's knowledge. And we should also clearly address the economic balances. In the first talk, we had the division by distribution of vaccines in the pandemic, where half of the high-income countries were vaccinated and the low-income countries had less than 1%. So this kind of economically based imbalances can no longer be there. We are trying to have a pandemic treaty. We are in the last, this week we have the INB 12. It's the last INB before some decisions will come out or not. We'll see. And what are the right-based governance? I think it's really important that we think health and human rights together. And the people who work for both sides stand together and mention it as one. And it is impossible to have the values of human rights when there are threats like the threats to normal human rights. Like I see a very important pushback on women's rights in the UN. In UN now, WHO is asked to get out the word gender out of all his papers. This is just something we couldn't think of. Russia in the last EB asked to get the word paternity leave out to be replaced by biological mother. Looks like small little pieces, but these are pushbacks on rights that we thought we have already acquired. Human rights, as we have seen with the AIDS pandemic, need a collaboration of top-down global health mechanisms together with bottom-up of an existing civil society. The civil society has to be there. And I think that we need a sustained political engagement to realize the right to health. It is a whole package, and it's a work of all politics as the famous political choice. I like to conclude by saying that we all know it, but health right for all can only be seen together with all the human rights. They have all to be there. And all the other human rights, the political ones, the social ones, have to be accomplished to have health. Health is depending on my political right, my free speech, my good housing, my warm and nice clothing, my nice company. All this is part of health, and we know it and we repeat it to ourselves. So governments and the UN level, the supranational level, they cannot do it alone. It always needs us the people, the civil society, to help and to work for it. And by this being said, I would like to thank you from Geneva, from our jet d'eau, and from the UN places. Thank you very much.
So thank you to all of our speakers. If I could extract one lesson from all of them, it is the importance for any of us who are working in public health to understand geopolitics. It may be the geopolitics of vaccine distribution, the geopolitics of global decentralized trials. It may be the global issues of universal human rights, and in particular at a time when we are seeing the international rules-based order under such attack, the attacks on the United Nations, the attacks on the International Court of Justice, on the International Criminal Court, the attacks on everything that was put in place after World War II. I think it is incumbent on all of those of us working in health to stand up for the rules-based order, particularly at a time like this, and of course, as we are here on this day. We know this is going to be very relevant, could be very relevant in the days and weeks ahead. So thank you all to all of our speakers, and I think we now have a little bit of ceremonial.
Yes,
You can
Professor
help me with
McKee,
this?
yes, would you please move to the center of the
Okay.
stage? Next, Professor McKee will be presenting certificates of appreciation to all the speakers in this session on the behalf of the organizer. So for that, we'd like to invite all our speakers back to the stage. Dr. Kuni and also Professor Suvada and Dr. Dalki and Professor Borish. Would you please join us on the stage once again? And thank you so much for your wonderful presentations. 那接下来呢，我们就要有请我们这个场次的所有的主讲人再次回到舞台上，要有请主持人的代表来致赠感谢状，一一的给我们的主讲人。
Oh, who do we have?
帮我们的主持人拿一下麦克风好吗？然后 Yes,
Oh.
firstly to Dr. Osamu Kuni. Let me hold the microphone for you. Yeah.
Thank you, that would be
Yeah,
easy.
yeah. Okay, thank you very much. And next to Professor Joseph Suvada. Thank you once again to Dr. Kuni and Professor Joseph Suvada. Thank you. And Dr. Aruna Staki. And of course, Professor Bettina Borish. Okay, everyone, would you please give all of our speakers on the stage another big round of applause? Thank you so much, and thank you so much to Professor McKee. Thank you. And that's it for the morning session, everybody. And now it's time for us to have lunch, okay? We have lunch boxes ready outside, and we'll be back by 1 o'clock. We'll be back by 1 o'clock to this very room for plenary session 1. Thank you very much, and we'll see you later. 那各位贵宾，接下来呢是我们中午休息的时间呢，我们场外备有午餐的餐盒，请大家呢都可以跟随我们工作人员的引导，到外面的用餐区来享用午餐。那我们下午场次呢是1点，下午场次是1点，再次准时开始，谢谢。 Ladies and gentlemen, the afternoon session will begin in a few minutes. Please take your seats. Thank you. 提醒各位贵宾，下午场马上要正式开始了，请您准备就座，谢谢。Okay, everyone, please take your seats. We'll begin the afternoon session. Thank you very much. 各位贵宾，请您就座，我们下午场次要正式开始了，谢谢。Welcome back, ladies and gentlemen. We hope you all have enjoyed your lunch. 非常欢迎各位贵宾呢继续回到我们的会场哦。And now we're in the plenary session 1. We're going to focus on global health diplomacy. 接下来呢是主场会议的第一场哦，我们要聚焦的是全球卫生外交。And now to open this session, please join me in welcoming your moderator to the stage. Ladies and gentlemen, please welcome distinguished chair professor Geng Liang of Fengjia University, Taiwan. 让我们掌声欢迎场次的主持人，逢甲大学梁庚义讲座教授。
Good afternoon. Thank you all for coming to this sections on the global health diplomacy. This is an issue that came to the health officials in Taiwan. We are honored to have 5 distinguished speakers coming from different countries to share with their experience in the global health in general and the global health diplomacy in particular. It's a little bit unfortunate. One of the 5 speakers, Professor Kate Bush, has canceled her trip because of emergency family matter to handle. So, but also that means it would give us a little bit extra time to spare, and also give me time to spend a little more time to introduce the distinguished career of all 4 speakers. And but I do want to make sure to have a little bit more time for panel discussion, maybe 20 minutes or so, more than the 15 minutes that we originally planned. So without further ado, our first speaker is Professor Keiji, hope I pronounced it correctly, Fukuda, from the member of the Board of Trustees for China Medical Board, United States of America. Professor Fukuda retired in 2021 as a director and clinical professor of the School of Public Health, University of Hong Kong. And prior to that, he served as at the WHO as Assistant Director General and Health Security and the Director of the Global Influenza Program. Before WHO, he served at the U.S. Center for Disease Controls as Epidemiology Chief Influenza Branch. Professor Fukuda trained in internal medicine before embarking on a career in public health that covered many areas, including health security and emerging infectious disease, medical communication, media communications, and health diplomacy. In the early 1990s, he led an international effort to define the chronic fatigue syndrome, which remains widely used today. I believe that this, the experience that was shared with us during his talk. And he also led numerous groundbreaking international missions for CDC and WHO to help countries investigate and manage notable infectious disease outbreaks, including the avian flus in Hong Kong and mainland China, also the Ebola in West Africa. And the title of his talk today is Global Public Health, Some Fundamental Career Lessons. Please join me to welcome Professor Fukuda.
Thank you, Professor Young. It's really with a huge amount of, it's with a huge amount of pleasure to be back in Taiwan and to see old and new colleagues and to be able to address this meeting. I want to thank the organizers for the invitation to join. Today, what I normally do is talk on a single topic and try to go into it in some depth. But today I'm going to give a somewhat different topic and give a broader talk about some of the experiences and lessons which really shape my thinking in global health. And my particular hope is to pass along some food for thought, especially for those of you who are early in your career, and I think there are a number of you who are in that situation. So my early professional training was in medicine and epidemiology. And it was quite technical. But once I entered my public health career, what I found was that many of the most difficult issues really had to do with non-technical issues, such as dealing with political sensitivities, or dealing with competing priorities, or when facing complex challenges, trying to figure out what was the right strategy. And so, like most of my peers, I learned by watching others, by talking with people, and also by experience and making my own mistakes. So the first experience that really deeply affected me started quite early. In college, I took a year off. It was kind of a gap year, and that was 1976. And I wanted to see the world, and so I left school, and I especially wanted to see Asia. I ended up going around the world and had quite a good adventure. But the reason for including or starting with that talk and starting this talk with that trip is because it was my first introduction to poverty, and really severe poverty. And to provide context, I had grown up in the United States in a small working class town in a quite rural area. None of my classmates were wealthy, but everybody had a home. But on this trip, I began to see forms of poverty that were new to me. And I saw them in places such as the Mexico-US border, in Hong Kong, and a number of other places. But in Calcutta, I encountered yet another level. And this was seeing families living on streets with small children. Some of the families were living under pieces of cardboard. And the impact on me at that time was overwhelming. I couldn't really process what I was seeing, but I also couldn't forget what I was seeing. After returning to the US and returning to school, I drastically changed my studies and decided to enter the health field. And part of the reason was it was a practical way to return overseas, but this time to work and not be a tourist. So I entered medical school, and in my second year, I met with a remarkable man, Dr. Charles Houston, who you can see here. He had been the first director of the Peace Corps in India and was a mountain climber. We talked, and during the discussion, he asked if I might be interested in working for a small organization in India. I jumped at the opportunity, and so I left school for another year. The organization was the Nilgiris Adivasi Welfare Association, or NAWA, and it was something that had been started by a local physician, Dr. Narasimhan, who you can see here, who worked in a small town, a small village in the Nilgiri Mountains of Tamil Nadu. And you can see Tamil Nadu on the map here. After finishing his regular workday, Dr. Narasimhan would hike into the hills and he would provide care to tribespeople, or the Adivasi. And what you need to understand is that in the context of Adivasi, in the context of India, the Adivasi are a quite highly marginalized underclass. And so then as other people began to learn of his work, he began to receive support, and Nawa basically grew up around him. Now, that half year of working with Nawa was one of the great experiences in my life and one of the best years of my life. So on a typical day, I'd walk with the chief physician, Dr. Ramasamy, and we'd go through a coffee plantation, we'd go through the forest, and then we would come to Nawa's main clinic, and we would see Adivasi Adivasi patients. And then in addition, during the week, we would also join a larger Nawa team to go visit a number of other Adivasi villages, and some of these were located in quite remote areas. The team would bring supplies, we would provide medical care, and then the rest of the team would meet with concerns of the villagers, and so finances, maybe about crops or about animals, and so on. Through this kind of daily interaction for those many months, I began to develop a more realistic understanding of the Adivasi, of Indian culture in general, and of my colleagues in Nawa. And because of that, India began to change in my eyes. When I was a student tourist, it had seemed mysterious and exotic. And the longer I was there, it simply became a regular place with people living normal lives. And that transformation in my orientation taught me that cultures and societies can differ a lot, but people are basically alike everywhere. And that understanding, that simple understanding, would underpin my entire career and the rest of my life. So earlier this year, with my wife, I returned to the Nilgiri Mountains after 40 years and visited Nawa. And I found that there is both continuity and progress. So Nawa's health work is now largely funded by the government instead of private donations. And Nawa also places more emphasis on the education of small kids. And so in this picture, you can see the principal, Dr. Puvisi. Now, Dr. Puvisi was a working physicist, and she decided to return to her town to take care of Adivasi children. And so as we spoke, she explained to me that she hopes to extend their formal education through high school, partly for teaching purposes, but also, she said, to shield them for longer from the stigma that they will feel by going to public school. So before I go on to other matters, I want to summarize a few key points from these early experiences. The first is the unique value of experiencing the world in person. There is nothing else that replaces seeing with your own eyes. The second is that the early exposure to poverty started a much longer process for me about learning about the profound nature of the gap between those who have and those who do not have. If you work in global health, as many of you do, you need to understand this gap, which is manifested in so many different ways, because finding realistic, durable, and meaningful ways to reduce this inequity is really at the heart of global health. So finally, the simple understanding that people everywhere share the same concerns, the same hopes, same joys, turned out to be a lifelong guide to me in finding ways to connect and work with other people. Now, Dr. Borish has already spoken a bit about AIDS and about ACT UP, but I want to re-emphasize some of the points that she made. In 1984, I went to San Francisco to start my residency training, and I want to highlight one large lesson from that period. The 1980s was pretty early in the AIDS epidemic, especially in the United States, and it was a period when a lot of young male patients would come to the hospital and they would die within a few days or a few weeks. AIDS was also a highly stigmatized condition, and the HIV community was fueled by fear, by anguish for those who were sick or who had passed on, and the rage at feeling ignored. And so in this setting, an AIDS advocacy group called ACT UP, again, which Dr. Borish mentioned, led protests such as closing the Golden Gate Bridge, shutting down the Opera House, and so on, and the results, as intended, were very disruptive. But much of what they said was true. And so later, at both CDC and WHO, I would work with a number of other advocacy groups. And sometimes when the discussions were difficult, I'd remember the reasons for why this advocacy group protested so passionately, and the essential truthfulness about much of what they said. And this helped me to listen better. So in 1990, my wife and I moved to Atlanta so I could train at CDC, and I stayed on in part to help define the chronic fatigue syndrome, or CFS. So at that time, CDC was under considerable public pressure to investigate CFS because there had been a number of highly publicized cases in the state of Nevada. Again, you can see where it is. Now, CFS is a chronic condition which is characterized by difficulty thinking, much in the same way that long COVID cases are described, as well as pain and fatigue. CDC was expected to characterize CFS and, if possible, figure out its cause. But at the time, a solid case definition was needed to facilitate research. So up to that point, I had had no experience with CFS, but soon found out that that community, like the HIV community I saw in San Francisco, also felt ignored, disrespected, and many in it were quite upset. So if you look at defining CFS, the question is, what's the issue? So what's a case definition? For scientists, it's really simply a tool to help facilitate and standardize research. But for the CFS community, they saw a case definition, and particularly one established by CDC, as potentially an important step toward gaining societal legitimacy, respect, and possibly things like disability compensation. But given the contrasting perspectives, it became clear to me that defining CFS was not so much a technical exercise or technical challenge as it was a political challenge wrapped in technical clothing. So I was really unsure of how to proceed, but invited both researchers and advocates to join the CDC effort in defining CFS. So that approach of mixing researchers and advocates was quite unusual. But the goal of defining CFS and the reputation of CDC was enough to attract the individuals that I hoped would join the effort. That process inevitably started off with tension and also mutual suspicion between the scientists and the advocates. But after a number of face-to-face discussions and meetings, trust began to build and discussions became more collegial. The resulting case definition was published in 1994, and it continues to be used today. So, in discussing the case definition, the larger point that I'm trying to make is on the importance of choosing a strategic approach. So in global health, virtually all issues are very complicated. All of them involve conflicting perspectives, and all of them require negotiations among multiple parties who have different priorities. And in that type of situation, the practical issue is having a game plan. Having participated in a number of such situations, both at national and global levels, it's clear that many different strategic approaches can be used. For example, a common approach is simply for parties to try to hide their intentions and gain an advantage. This is a little bit like playing poker. But at the risk of sounding simplistic, what I found was a win-win strategy, when possible, is best. Making sure that all of the significant issues are visible makes it easier for all sides to accept compromise in order to achieve important gains. But practically, the success of this kind of approach often depends on having someone who is trusted on all sides to moderate or to act as a go-between. So at the global level, this is often the role played by WHO. So I now want to switch to emerging infectious disease outbreaks and their consequences, which is an area which was a large part of my career. So currently we live in an era in which awareness and concern about pandemics has become widespread. And this is because of some highly publicized outbreaks which have been mentioned, but like SARS and Ebola, and most recently COVID-19. But I want to particularly focus on avian influenza H5N1, which is often called bird flu, and SARS, because these infections, along with HIV, were the ones which really ushered in the modern era of pandemic awareness, and their emergence had a global impact. So in 1997, an outbreak of H5N1 occurred among residents of Hong Kong and greatly caught influenza experts by surprise. A total of 18 people were infected and 1/3 of them died. And during the investigations, many of us thought at the time that the world was on the verge of another 1918 level pandemic. That's a pandemic in which 50 million people died. After testing showed that H5N1 was widespread among poultry in the wet markets in Hong Kong, all the poultry in Hong Kong were culled, and the immediate outbreak ended abruptly. This event put the influenza field on alert and initially received a lot of attention. But the attention by policymakers and non-specialists soon faded after no new cases were reported. A few years later, in 2003, two new important events took place. The first was the emergence of SARS. That virus started infecting people in southern China, in Guangdong province, in late 2002. And then a few months later, in February of 2003, it started spreading internationally through travelers, initially to Hong Kong, Vietnam, and Canada. And then SARS would go on to then cause over 8,000 cases in 30 countries and territories, and had a case fatality rate of around 10%. It heavily impacted Taiwan. It was contained by July, but caused a huge amount of global anxiety. Now, the second event that year was the return of H5N1. Toward the end of the year, a large number of poultry began dying dramatically in Asia. The cause of that outbreak was a newer version of H5N1, the virus that had caused the outbreak in Hong Kong. This virus started spreading to other global regions, causing deaths among poultry and also people, as well as a large number of mammalians or mammals. Now, these events had several important consequences. One was the adoption of the international health regulations by WHO member states. This is the global framework for how countries can prepare and cooperatively respond to public health emergencies. Negotiations had been ongoing for a number of years, but SARS and H5N1 created a new sense of urgency, and this pushed member states to complete the negotiations. The adoption of the IHR in 2005 was a milestone in global health diplomacy. They were used to great advantage in the 2009 pandemic of influenza, but they were not used very much during COVID-19, and because of that have undergone another revision. Now, a second consequence of the emergence of these viruses, and particularly H5N1, was a decision by WHO and the Food and Agriculture Organization, or FAO, and the World Organization of Animal Health, which at the time was called OIE, to form a so-called tripartite alliance. These three organizations spearhead human and animal health at the global level. And they realized that H5N1 posed a significant threat to people, to animals, and to the food supply, and that none of the organizations in isolation could address it. So they formed a partnership, and the partnership became a strong example of One Health in action. And this tripartite went on to play a unique and indispensable role in bringing the issue of antimicrobial resistance to the United Nations, and I'll come back to this. Now, a third impact of these viruses was more complicated. In 2007, Indonesia stopped sharing H5N1 isolates with WHO. The Minister of Health at the time argued that the viruses being provided by Indonesia were being used by companies to create vaccines and pharmaceuticals that were not affordable. And so why should Indonesia share its viruses with WHO? The global north was alarmed and responded that the sharing of viruses, especially those potentially capable of causing a pandemic, was essential for both providing global warning as well as for developing countermeasures such as tests, vaccines, and so on. So this disagreement led to 4 years of very difficult negotiations. The breakthrough in those negotiations occurred when the lead US and Indonesian negotiators, both of whom were ambassadors, jointly announced in a plenary session at WHO that the sharing of viruses and the sharing of benefits were on quote-unquote equal footing. Maybe 3. But I think we have a little bit of extra time. So this allowed the member states to complete negotiations, and this resulted in adoption of this pandemic influenza preparedness framework, or the PIP framework. The PIP, like the IHR, should be regarded as a major achievement in global health diplomacy. But the one aspect I want to point out about it is that the PIP concretely quantified the concept of benefit sharing in relation to pandemic influenza vaccines and antiviral medicines. So if you look at it, it tells specifically how much of those vaccines and countermeasures should be donated to WHO to be provided to other countries that cannot obtain them. The PIP agreement has not yet been tested. It hasn't been tested in a pandemic, but it's in an influenza pandemic, but its concepts have been important in the current treaty negotiations on, or pandemic treaty negotiations in Geneva. So The last experience I want to highlight is related to antimicrobial resistance, or AMR. So in 2012, a Swedish delegation came to WHO and spoke to me about AMR and voiced their concern that WHO and the world was not doing enough about it. I listened to them and I agreed with what they said, but I had to carefully consider what to do. AMR is a phenomenon in which genetic changes in microorganisms like bacteria lead to resistance to medicines like antibiotics used to treat those infections. And the implications are enormous. So this year, Chris Murray's group in Seattle estimated that in 2019, 1.3 million people died from AMR. And they project that by 2050, as has been mentioned earlier, that as many people will die from antimicrobial resistance as cancer, about 10 million people per year. AMR also threatens food security. So the relevant context for what happened is that AMR had been a priority for infectious disease specialists for decades, but despite a lot of warnings, a lot of studies, and a lot of guidelines, levels of AMR had continued to rise worldwide. So at that time, in my view, the fundamental issue we were facing was that AMR was simply too large for the health sector to address alone, and that broader societal engagement was needed, for example, from pharmaceutical companies, the agriculture and food sectors, and so on. But the question was, how do you encourage that kind of engagement? A small group of like-minded individuals, and especially Sally Davies from the UK, who continues to be at the forefront of the fight against AMR, and the ministers of health from the Netherlands and from Sweden, myself and some others, started working closely together. One goal was to bring AMR to the United Nations as a means to gain broader societal and political engagement. And so we took several steps towards trying to accomplish this. One was to use peer-to-peer relations and discussions with ministers, with ambassadors, with representatives of groups like the G77, as well as professional societies, industry, funding agencies, media, and so on. The second action was to ask the UK's Prime Minister, who at the time was David Cameron, for support. And he agreed, and the UK's diplomatic support, the diplomatic network, played a uniquely important role in getting the issue to the United Nations. A third stream was for the tripartite to gain member state support for this issue. And so the WHO, in close coordination with FAO and OIE, initiated a process to develop a global action plan as a means to consolidate global expertise and to provide a global blueprint for what to do. And then each of the tripartite organizations had their governing bodies, which are composed of member states, formally approve the plan as a way of gaining higher level buy-in and engagement. So in 2016, in September, the UN held a high-level meeting on AMR at the level of heads of states and adopted a resolution. This is only the fourth time in the history of the UN up to that point that a health issue had been taken up by the United Nations. But this year, a second meeting was held as a kind of follow-up to that first meeting. So let me provide some perspective. We took existing and ad hoc processes and adapted them in coordination to achieve what was really a quite ambitious societal political goal. The strategy succeeded because the issue was substantive, because the process marshaled wide support, and because trust was maintained. These were the essential ingredients. So when a member state representative asked me in private, are we being fooled by industrial countries in a way we cannot see? I was in a position to say, no, the dangers and issues in front of your country are real. So, my last slide. So I just want to end on this closing note, again, intended mainly for people who are earlier in their career. First, I just want to reiterate, there is no career which is more satisfying than working on the health of others, whether it's individuals, local communities, or global populations. The size of the group simply doesn't matter. But I learned in my career that certain things do matter. It's really important to experience and learn from the real world as much as possible. Health is part of the real world, and it's not an abstraction. Learn to identify the fundamentals of a challenge, because good solutions need to address real issues. Listen to and respect all sides. Choose a win-win strategy when it's possible. And be persistent, adaptable, and optimistic. Global health issues are very difficult, but good and realistic advances are possible. Thank you. Sorry for going over.
Thank you, Professor Fukuda, for your excellent presentation and through numerous experience you had. You share with how one deal with global health issues. And then the couple of phrases come to my mind, and one is the trust negotiation. The other one is paraphrasing everyone in the world are similar to each other. We need to respect with each other. Our next speaker is Dr. Bernhard Fettinger, who is the former minister plenipotentiary in health of Australia to the UN in Geneva. Trained in law, Dr. Fettinger changed his career in public administration in the 90s by working as a legal expert at the Federal Chancellery and later on in the Federal Ministry of Health. Having returned to the Ministry of Health in Vienna, he worked in various departments of the Ministry of Health, including the position I just referred to. And in these functions, he also was also the EU burden sharer for several topics, such as the medical device nomenclature and the polio, in the context of constitutional meetings of governing bodies of the World Health Organization. And the title of his talk today is Public and Global Health Campaigns That Had a Big Impact, Requirements and Reasons for Their Success. Please join me to welcome Dr. Fettinger.
Good afternoon, everybody. Honorable ministers, distinguished guests, dear colleagues and friends. It's a pleasure for me to share with you today some views and ideas about successful public and global health campaigns that made a difference. My professional background is that of a long-time collaborator of the Austrian, not Australian, if I may correct this little misunderstanding, of the Austrian Ministry of Health. Then the difference is the kangaroos. We have less kangaroos in Austria than in our larger, similar sounding country, Australia. And in this function as collaborator of the Austrian Minister of Health, I also served as a health attaché and minister plenipotentiary to the UN in Geneva, where I could gather a lot of experience in this field. As all of you know, the progress towards achieving the SDGs, SDG targets, and in particularly, of course, SDG target number 3, was impeded considerably by the COVID-19 pandemic and other ongoing crises. In this situation, public and global health campaigns can provide significant tools to improve health systems as well as health literacy. Actually, I'm going to use the term campaign in a double sense, or in two different senses. First, this term refers to major joint activities and programs of the World Health Organization and other stakeholders aimed at reaching certain global or public health goals, like the WHO-led groundbreaking smallpox eradication initiative, or the diarrheal disease control program established in 1978. Using them just as an example to reflect about the requirements and reasons and lessons learned for the success of such major initiatives or programs in the field of global or public health, respectively. Secondly, I'm going to use the term campaign in the sense of public service announcements, PSAs, or health communication campaigns run by public or private entities. The interesting question for me here was whether we can discern common critical success factors in the context of these campaigns. So let's start by having a closer look at the historic WHO-led smallpox eradication initiative, which was started in 1967 and finally succeeded in reaching its goal in 1980. What were the reasons and preconditions of its success? Smallpox eradication succeeded for a few very special reasons and due to very particular success factors. Success factor number one was the relatively easy diagnosis and surveillance of smallpox. Success factor number two of this campaign was its, again, relatively easy containment. Number three was the level reached in vaccine technology, which had at that time advanced to a point where eradication was a feasible proposition, as the vaccine had become heat stable thanks to the use of air-dried or freeze-dried vaccines developed in the early 1950s. Success factor number four was that the vaccination was inexpensive, provided protection with only a single inoculation and could be administered anytime from birth onward. Finally, its application had become easy due to the use of the new bifurcated needle. So what lessons does the smallpox eradication experience provide for us? One important lesson of this experience is that eradication is extremely difficult, even when a heat-stable and highly efficient single-dose vaccine is available, and the epidemiological characteristics are as close to ideal. That means that eradication is not a program to be undertaken lightly. Sufficient resources, effort, and cooperation alone are not a guarantee for success yet. Lesson number two is that eradication programs are expensive and hard to finance. Lesson number three is that, for me, is that the necessary technology clearly has to be available. Furthermore, the feasibility of eradication must already have been proven in practice before the program starts. By these means, as lesson number five, the risk of costly failures of such campaigns needs to be minimized beforehand in order to avoid a loss of professional public health and medical credibility. But finally, if eradication succeeds, the cost-benefit ratio that might be achieved is dramatic. In the case of smallpox, the combined total international and national investment was estimated to have amounted to perhaps 300 million US dollars, while savings due to the end of vaccination and quarantine measures of at least 1 billion US dollars have been realized since then annually. A second example for an extremely successful global health campaign, I would like to briefly look at the Thyroid Disease Control Program established in 1978. As I suppose that most of you are familiar with the technical details, I shorten my discussion, my lecture a little bit, and come to the lessons learned from this campaign. Firstly, it took also sufficient empirical and scientific evidence had already been available since the late 1960s, about 10 years for its use to be finally accepted by the WHO in 1978. That means it was in the middle or at the end of the 1960s that this method of ORT was invented and tested, but it lasted 10 years for WHO to really establish this diarrheal program. Or in other words, as an author put it, we only adopted the use of the oral rehydration therapy more than a decade after we landed on the moon. The relevance of this treatment can be expressed or described by that it costs millions of lives every year, the cholera dehydration. I think that this deadly delay of about 10 years before the WHO finally started a concerted action would deserve some more in-depth research for identifying its root causes and background. One of the explanations for this slow recognition of ORT is that Western doctors were skeptical of adopting treatments tested in countries of the global south because they considered them to be of a lower standard. Another possible reason might be linked to what we nowadays call commercial determinants of health. Given the fact that ORT, oral rehydration therapy, is a much cheaper treatment than IVT, with average costs of around 0.5 US dollars per course, compared to overall costs between 450 and 80 US dollars per course of an IVT treatment in a clinical setting. In part 2 of my reflections about successful global and public health campaigns, I would now like to have a quick look at successful public health communication campaigns. Among the long list of outstanding models for such communication or awareness campaigns are, for instance, the British multimodal public awareness health campaign, Know Your Lemons, Worldwide Breast Cancer, that has reached so far about 1.5 billion people and saved thousands of lives. Could you please show the slide? Oh yeah, we can see it already. For me, this public awareness health campaign is a most inspiring example how creative and innovative intelligent solutions, communication solutions, can be found by spreading life-saving information and to increase critical health literacy, even when taboo-stricken anatomy is concerned. These posters and related information material have been successfully used also in several Islamic countries around the world. Another salient example for such a communication campaign that had a big impact is the American public health sorry, can you also show slide number 2? It's the green slide, the second one. I can try to.
可以帮忙往下按吗？
Okay. Oh yeah, here it is. You see again, they use a lemon as a symbol, and this is has no problematic connotation. So it's an excellent and intelligent idea how to illustrate the problems in this respect. Another salient example of such a communication campaign that had a big impact is the American public health campaign Choose Anti-Smoking Initiative, which was founded in 1999 and has contributed to a nationwide decline in teen smoking rates. For example, by using engaging ads such as the famous Singing Cowboy video, which I would like to show you now. Please, can you start the video? It doesn't work? It's a video. Oh, yeah.
That's for you.
Yeah.
Nah. Oh. Okay.
Mark Jones?
Hey.
That's not the
We
Singing
need you
Cowboy.
to step out
Sorry.
of your head for a moment.
It's a different one. Okay. We can watch it as soon as it's available. Our colleagues are working on it. I'm truly convinced that we, the representatives of the health community, do have the moral obligation to create an effective counterweight to the massive lobbying and ad campaigns constantly pouring down on the population.
Dr. Fattinger, I
Yeah.
think the video is ready.
Okay,
Yeah,
please,
it's this
can
one,
you
right?
start it?
Okay.
You don't always die from tobacco. Sometimes you just lose a lung. Oh, you don't always die from tobacco. Sometimes they just snip out your tongue. And you won't sing worth the heck with a big hole in your neck.
'Cause you don't always die from tobacco.
'Cause you don't always die from tobacco. Yippee-ki-yo.
You see, that's quite emotional and touching and has really had a considerable impact. The smoking rates among young adults in those parts of the country where it was shown dropped considerably. So I continue. I'm convinced that we need to make sure that health too has its lobbying and its communication and ad campaigns. A third example to be mentioned here is the Indian countrywide government sanitation program Swachh Bharat Mission, initiated in 2014 which deals most successfully with the extremely relevant topic of having safe and accessible toilets available everywhere for the population, including in rural areas. If done right, these public health campaigns are highly effective ways to raise health awareness and literacy, communicate prevention and healthcare goals, strengthen patient engagement, and produce better health outcomes. These factors encompass, among other things, a sound scientific background or high level of creativity and innovation, respectively. And among other things, I have to shorten it a bit, the willingness to take risks. Successful communication campaigns understand their audience, are well targeted, use visual elements and multiple channels to capture attention, and are accompanied by constant monitoring and evaluation. There would be a lot more of examples worthwhile to be mentioned. I just would like to quote briefly one which is dear to my heart, or two of them. One is called Calm. Suicide doesn't always look like suicidal. I repeat, Calm. Suicide doesn't always look like suicidal. And Dove, the real cost of beauty ideals about body dissatisfaction. Again, the topic of body dissatisfaction among young women is incredibly important, not only with regard to its health consequences, but also with regard to its economic costs. There is an estimation, I couldn't check it, but it says that the overall damage to the US economy resulting from this body dissatisfaction among young women goes to billions of US dollars. And the other topic, suicide, is mainly relevant for young men. And there are several of these videos available and ad campaigns which are really worthwhile watching. So what makes a good mental health campaign? First, they are authentic. Secondly, they are guided by data. For example, research data shows that younger people are typically more likely to experience mental health issues. Over 1 in 4 Generation Z and millennials, they say that they are prone to anxiety. And the huge 82% of these same groups in the US say they would like to see more of a focus on mental health in health care. And a third element is that they include a clear message and call to action. There's a consistent message running through all the mental health campaigns covered here. We need to start talking about mental health. And no matter how bad someone feels, they are not alone and help is available. This simple but impactful message can make all the difference. And finally, one more side, I'm coming to that. We baby boomers need to understand that our young adults live in a different world from ours. That is the virtual world of social media, etc. For them, it's a real world in which they spend a lot of their time. If you want to reach and better protect them, we therefore need to communicate with them and meet them there, in their own age-appropriate language and on their channels. This is a huge challenge for all our public health administrations, which we have to face and accept and to implement urgently. And the last sentence is, my proposal or my idea would be why don't we exchange these excellent ads, campaigns on an international level? We don't need to reinvent the wheel. When there's an excellent campaign like this in the US or in Australia, why not use it also in Europe? This would be, I think, a very good and innovative approach, cost-effective, and it's really necessary just to take action in this field. Thank you very much.
Thank you very much, Dr. Fettinger, for your excellent speech. And through different kind of campaign initiatives, such as smallpox eradication, free tobacco, and also HIV over the half centuries. And Dr. Fettinger emphasized the importance of several successful factors for such campaign to be successful, and also mentioned to it. With that, I think that hopefully that we do the right, we can raise the health awareness and literature to communicate the prevention and the healthcare goals, and strengthen the patient's engagement, and to produce better health outcome for all of them. And at the end, I think he mentioned several important points about the mental health, and also the difference in thinking for different generations. I think. And there's so many campaigns, so many ads have been produced. I think why can't we just use them instead of reinventing the wheel? Then our next speaker is the Rear Admiral, the Honorable Rebecca Patterson, who is the Senator for the Senate of Canada in Canada. Senator Patterson is a 34-year Canadian Armed Forces veteran. As a provider and the executive health leader, she worked in military healthcare delivery, education, training, and operational and strategic planning, both at home and on international deployment. Senator Patterson had led in many different domains in the Canadian Armed Forces, from serving as the defense champion for women, addressing sexual misconduct, and leading culture change efforts in the forces, to commending Canadian Forces Health Service at the height of the COVID-19 pandemic. She also has been a strong advocate to transform the culture, eliminate the harmful behaviors, and re-establish public trust in the Canadian military. And finally, I think she is the first military veteran who is woman appointed to the senator in Canada. And the title of his talk today is the universality of health as human experience, and how health diplomacy is important to human and the health security. Please join me to welcome Senator Patterson.
Just getting everything set up here, making sure you can hear me okay. I really do feel like I'm on a pedestal. I don't think I've ever been this tall in my life, so good afternoon to everyone, and thank you to the organizers of the 2024 Global Health Welfare Forum. And being the 20th anniversary, it shows you how important having global meetings like this are. And again, I'd like to thank Dr. Tae-Wan Chu, Minister of Health and Welfare, and the Ministry for his kind invitation to attend and speak on the topic of global health diplomacy. Now, you're probably wondering what a military person could possibly say about global health diplomacy. And as you can imagine, I have a healthcare background. And my intent today is we've heard some fabulous speakers who a lot of what they have said, I keep thinking, ooh, I think I was referring to that. But what you will also find, especially in an increasingly unstable world, is that global health diplomacy is very much part of what makes our nations resilient from a health and security perspective. So what my intent will be is to find a link and give a slightly different lens on what we've heard and look at it through a human security lens and what that actually means to us as practitioners in health and global health diplomacy. So as you heard, before I was summoned to the Senate of Canada, I've served for 34 years in the Canadian Armed Forces, and I worked as a nurse practitioner, a registered nurse, and later as a health leader and an executive, and also a strategic military leader. I was also deployed multiple times, including to Afghanistan, where I helped the Afghan National Army and the Afghan National Police reestablish their medical education and training systems. And it was during this 13-month immersion into the benefits of health diplomacy, while working to enhance capacity and resiliency within foreign nations, really helped me understand the value of nations working together to increase the health of a population. So like everything, the definitions are great. So I'm going to look at health diplomacy through a lens that refers to the intersection of health and foreign policies, because I have to be a politician just a little bit. And it's where nations work collaboratively to address global health challenges. But also, as a senior military leader and now a senator, I have witnessed firsthand the positive results that dialogue and diplomacy can have locally, nationally, and internationally on the health and security of individuals. And as we've heard previously, it doesn't really matter what your culture is. People want to live safe and secure with good health, strong families, and access to the benefits that society has to offer. So why should nations at the political level concern themselves with participating in global health diplomacy? Because we look at what unites us all, because health or lack thereof is that one universal human experience that we all experience. Every person on this planet experiences health or lack thereof, and it affects everything. And in this increasingly unstable world, states have a responsibility to not only protect their physical borders, but also their populations, because it's only then will states remain resilient and united in the face of both naturally occurring and man-made threats to our very existence. And I believe that as a domain within the global security, health security and the accompanying concept of global health diplomacy are essential for attaining what the Millennium Development Goals refer to as freedom from fear and freedom from want for every human being. And I know nations have adopted these concepts differently, but for me, these resonate true to my heart. And so I think the first thing, we've heard a lot about human security today, but let's kind of step back and think, well, what is human security? So from a historical perspective, it emerged in the years after the collapse of the Soviet Union and at the end of the Cold War. Human security looks to move beyond the traditional concepts of state security or policies and actions aimed at securing a state borders and their people from external attacks, but it shifts the focus and integrates the requirement that looking at people of the state as individuals within the context of a functioning society rather than just a homogeneous component of state, it's just as important to look at security in these domains. So as this security agenda has emerged, and there is a lot of debate and discussion as to what exactly it means, but it has generally identified 7 threat areas that need to be looked at internal to a nation in order for that nation to truly be considered a safe and stable democratic state. Now, I'm going to be very biased here and use democracy as I know it as a Canadian. And I will speak from my Canadian perspective, because what we do know, even at home, is that insecurity or instability in any of these 7 areas make it a lot harder to govern, a lot harder to engage, and can contribute quite significantly to the impact the very democratic institutions that we have established, and can undermine trust, contribute to unrest, and at times inter and intra-state conflict. So just to review, and I think you're going to hear yourself hear the social determinants of health here, but these 7 pillars of threat assessment that we need to look at are things such as economic security, where people need to feel safe and secure about their ability to live without want in a society. Food security, people need physical and economic access to food. Environmental security, and this is where global warming comes in. Protection from the short and long-term impacts of natural and man-made environmental threats and disasters such as global warming. Another pillar is personal security. It's protecting people within a state from state-executed violence and from interpersonal violence. Community security, because people live within a context. People must feel safe and secure in the communities from where they live. And what really matters in my current work is political security, protecting and honoring people's basic human rights, ensuring opportunity to freely engage in the political systems that make decisions on governance, and their ability to hold their leaders to account. And the last pillar, or the 7th pillar, which is really relevant to what we've heard a lot of today, is in terms of human security. And I'm going to talk at a very basic level for people to feel secure where they live, regardless of where they come from. And health security looks at ensuring that a state provides equitable access to health care to keep populations healthy with at least minimum protections against unhealthy lifestyles and diseases. So I cannot help think about these linkages to what Canada defines as the social determinants of health, and acknowledge that they're inextricably linked to what could effectively be considered the human security determinants of safe and democratic societies. And this is why I believe it is important for states to engage in global health diplomacy, to collaboratively share our best practices, our experiences, and our resources as a matter of foreign policy. Because virtually the very same determinants that we, within this global health diaspora, use to assess the health of individuals and communities, it can also be used by governments to measure their nation's success and ensuring that their people feel safe and secure within their own borders. So let me provide some backstory on the concept of human security from a Canadian perspective. Canada was an early leader in the emerging concept, because it's a construct that we have developed, not us, globally. And this concept of human security, which was championed by then Canadian Minister of Foreign Affairs, the Honourable Lloyd Axworthy, and Canada looked to leverage its historical reputation for peacekeeping. It was, after all, a Canadian who developed and actualized the first peacekeeping force in 1956, to pivot Canada's foreign policy from a Cold War mentality to that of a leader in peace and development. And in the time since the end of the Cold War, the world has come together to combat global terrorism, religious extremism, global famine, and disease in multifactorial ways. And while not all the results have been as positive as we probably would have liked, it's in my opinion that, as an example, these concentrated global actions have been aligned with this whole concept of trying to establish security within borders, whether it is ours or within an ally. And recently, and we have certainly seen a certain amount of pushback to that concept, where you find that you have competing domestic demands for resources, and they push nations, including Canada, to set back to our default of focusing our traditional investment concepts in terms of our border or our state security. And if we just focus there, and focus on ourselves, we can certainly see some of the great global challenges stepping back, especially if you were to take the example of the onset of the brutal and the unprovoked and ongoing Russian war of aggression with Ukraine. But even then, all is not lost in the realities of a modern world. And we'll see that the parallel concept to address some of these elements of the global human security are at work among those supporting and standing with Ukraine. And I certainly give a shout out to our host, Taiwan, and what they have been contributing. Because we also know, for example, that despite global economic uncertainty, donations from supporter countries have not just been arms and artillery and ammunition to Ukraine. They've also been things like medical supplies, advising, mentoring, supporting, and modernizing health systems, and also providing medical care outside of the country of conflict. It's soft power diplomacy at its finest. And another shout out to our host nation. Early in the war, did you know that Taiwan donated 27 tons of medical supplies to Ukraine? This is a recognition of the effect of the war, of the people in, effect of war to the people in Ukraine, and particularly in support of the Ukrainian people's resilience in the face of the ongoing onslaught. The war in Ukraine is one example of why global health diplomacy is so important today, because the United Nations Secretary General Ban Ki-moon said in 2015, human security depends on health security, that one thing all of us experience. And it's in my opinion that the best way to achieve global health security is through systemic engagement in global health diplomacy as a matter of policy. Global health diplomacy may be a relatively new concept in some places, but I have to tell you, if you look back just from what we've heard today, countries have been engaging in non-traditional, real power diplomacy for some time now. And we know that global health issues do not care about borders, especially on the natural side. So whether it be viral outbreaks and pandemics like SARS in 2003, which you heard hit Canada heavily, or COVID-19 in 2020, which hit us all, we have all witnessed that simply retreating into a country's borders did not protect our populations. COVID-19 showed us that states around the globe need to better engage with one another to address issues of health security through the global health diplomacy, because if we do not learn from our shared experiences, both successes and mistakes, we're all doomed to fail as a society and a species. And as I mentioned previously, global health diplomacy refers to the intersection of health and foreign policy, where nations work collaboratively to address global health challenges. It may take many forms and may operate in many ways because only your nation knows what it can look like. But it will involve negotiating, forming partnerships to enhance health outcomes, sharing of resources, and responding to health threats that transcend national borders, such as pandemics, infectious diseases, and health inequities. And yes, I can tie global economic instability into the ongoing wars around this world. So it's also my opinion that like-minded nations can leverage global health diplomacy in several and impactful ways. And what have we thought about strengthening global health security by, again, as we've heard, collaborating to build robust health systems in emerging countries so that people can have confidence in the system and help prevent the spreading of infectious diseases and ultimately feel like their democracies are supporting them? What if we promote programs that support vaccination, health education, disease surveillance to prevent and mitigate global health threats? And we have certainly heard some examples here today. To promote universal health coverage, which even in every country here is not a reality for all. And you can advocate for universal health coverage to ensure that essential health services are available to all people, regardless of economic situation or their intersections of identity, because no one can be left behind. Because such efforts can create these stable communities that are so important to a resilient democracy, and which in turn reduces the need for humanitarian interventions, which can build confidence, and which can help those countries who have been placed at risk. addressing health inequities at home and abroad by sharing knowledge, resources, and technology as a matter of policy. And they can help address these issues, such as maternal and child health, malnutrition, and access to clean water, as part of our basic determinants of health. We can properly respond to health crises collectively by taking a lead role in international response effort during times of global health emergencies, by doing the sharing that we focused on today, whether it be scientific information, funding, supplies, and facilitating health research efforts to improve health outcomes, and fostering public and private partnerships between governments, NGOs, private sector, to leverage the various resources in tackling global health issues. I think everyone here can provide examples of where there are silos of effort and excellence that don't intersect, which don't necessarily help populations that we are there for. It just creates confusion and competition in a very stressful place. And then lastly, collaborative initiatives can accelerate innovation and improve access to health technologies globally, but particularly in under-resourced areas. Actions as those that I've listed above not only help improve global health outcomes, it can also help nations improve their standing in the global community by demonstrating their commitment through global health to global security. And because after all, we are stronger together. But more importantly, we know improved global health outcomes improve local health outcomes in this very interconnected and global world. Now, I've mentioned earlier, noted, that connection between global and local outcomes is important because sadly too often, and I wish to reiterate this, that we have domestic policies and politics and we keep health separate from all of those. I remember the spaghetti bowl that we saw of all the interconnections from one of our previous speakers. Health transcends all levels and must be considered from a politics and policy level, and we can hold our politicians accountable. And as Canada's Mowat Centre notes, governments have trouble solving big, complex problems, in large part because governments are organized into collections of narrowly focused vertical silos. And as health leaders, we cannot allow that siloing to happen in the domain of health. I'd like to point out that successfully engaging in global health diplomacy, states and nations do not need to be great powers, and I would like to give another shout out to our host today. They could be middle powers like Canada and Taiwan, who can develop their expertise and make use of soft power diplomacy to achieve results in improving health security. And speaking of Canada and Taiwan, the 2023 Memorandum of Understanding on Health Cooperation, which established structured cooperation in the health sector, including health security, between our two sides, is an example of that fabulous health diplomacy. The MOU is a major step forward in our relationship specifically, and for Taiwan seeking like-minded partners to engage with in general. But Canada and Taiwanese health cooperation is not new, and it's spanned many generations. I'm reminded of the work done by Canadian missionary George Leslie Mackay, and I know his legacy is still felt across Taiwan. More recently, Taiwan's generous donation of approximately 500,000 surgical masks to Canada in support of our fight against COVID-19. And I'd be remiss if I did not thank the Taiwanese Embassy in Ottawa and the work of the Canadian-Taiwan Parliamentary Friendship Group has done to advance those donations. That demonstrates that global health diplomacy does not always need to be on a government-to-government level, and it also exists on a person-to-person level, just like us having conversations today. But health diplomacy can also be multilateral. As such, Canada continues to advocate for Taiwanese participation in multilateral forums, particularly the World Health Organization and Assembly, and this is consistent with Canada's approach to soft power influence through the engagement with like-minded partners with increased attention paid to human security. In closing, as the health and welfare practitioners, administrators, professionals, and executives know that issues like COVID-19, climate change, migration, increasing health inequities, and other complex global health issues transcend national borders and impact us all. This is why it's so important that like-minded democracies like ours engage in global health diplomacy as a matter of policy and national global security. Because for global health diplomacy to work and for health security to be successful at a state level, like-minded democracies need to work together. We cannot let authoritarian and autocratic regimes silence the voices like Ukraine and Taiwan, because as the Canadian House of Commons Special Committee on Canada People's Republic of China relationship noted, and I quote, ensuring that Taiwan does not fall is incumbent on all democracies. Again, I want to thank Dr. Tai Wan-Chu, Minister of Health and Welfare, and the Ministry for this very kind invitation to have myself and my fellow Canadian senators attend this forum. It's my sincere hope that participation of us in this 2024 Global Health and Welfare Forum in Taiwan will help not only further Canada-Taiwanese health diplomacy specifically, but our two nations' health diplomacy and efforts collaboratively together. Thank you.
Thank you very much, Senator Patterson. And she talked about the health security that really reminds us it really is a part of human security, which covers important issues, global warming, disparity in economics. So really, when we think about the health, it really has to think globally. And I think she reminds us that it takes collaborations across global. And there's I think the relative new concept in PPP, the private-public partnership, really shouldn't be limited to on the national level. Should be on the universal level. I think that she mentioned that for the effort to be made for each country, it doesn't have to be the super military power. Countries such as Canada, such as Taiwan, could be important partners as well. So she mentioned about the initiative, the collaborative initiative between two countries last year, and I couldn't help but believe that Senator Patterson was behind that as well. Our last and definitely not the list speaker is Honorable Professor Dr. Andrew Oman, who is a member of the General Bundestag and the chairman of the subcommittee on global health and Federal Republic of Germany. Professor Oman is in the second term as the elected member of the German Bundestag. Trained as a physician, Professor Oman is member of the Health Committee and serves as the spokesperson on health of the Free Democratic Party parliamentary group. Professor Oman is also the chair of the subcommittee on global health of the German Bundestag. Professor Oman has background in infectious disease and was trained in hematology and oncology. And the title of his talk is The Future of Global Health, Governance and Financing. Please join me to welcome Dr. Oman.
Professor Liang, ladies and gentlemen, thank you for inviting me this afternoon being here in Taipei. It is a great honor to talk to you about global health and especially about the future of global health governance and financing, which is a big challenge for all of us. It is obvious that our world is at a crucial juncture facing interconnected challenges that impact global health, just as old or ongoing and or future pandemics, climate change, health inequities, political and economical instabilities and conflicts. And addressing these issues requires a global health architecture that prioritizes resilience, equity, and cooperation. Today, my presentation will center around four main areas: reforming global health system, participating the role of institutions like the WHO, global health financing, strengthening health diplomacy to build collaborations and empowering parliamentarians as bridge builders for effective action. So where's the necessity actually to evolve global health governments? The urgency for change has never been clearer. Recent pandemics exposed us to several gaps of our government structure, from vaccine inequities to fragmented responses. These failures demonstrate the need for a system that ensures equitable and timely resource distribution to manage global health crises and crises effectively. Climate change. It is obvious that the climate is changing, and it further complicates healthcare landscapes by intensifying disease spread, food insecurity, forced displacement, and requiring it to be central in health policies. Health inequalities remain a persistent global issue, disproportionately affecting low and middle income countries and rural communities, as seen during the pandemic. Health inequities. More than half of the world population is not fully covered with one or more essential health services. About 2 billion people face this financial hardship due to out-of-pocket health spending. Disparities in health care access highlighted by the pandemic require a shift toward universal health coverage and inclusive policies. It is essential that all populations, regardless of income or geography, have an equitable access to health services. Economic instability. Economic instability compounds these challenges as the health needs for low and middle income countries grow while external aids declines, making it essential to view health spending as long-term investment rather than short-term cost. And the conflicts further exacerbate health crises as damaging infrastructure, forcing displacement, and heightening the risk of disease spread. In the current global health landscape, a fundamental debate is whether the system operates more like a structured architecture or a competitive marketplace. At present, it resembles a marketplace with various actors competing for funds, visibility, and influence. This structure often leads to mission creep, where organizations adjust their mandates to maintain relevance and complicating the global health ecosystem. By shifting to a more, that's always happening. By shifting toward a cohesive architecture, we could reduce redundancies and improve alignment, but this requires a significant reconstruction of current funding and organization models. At the heart of the World Health ecosystem is the World Health Organization. And I think I went too far. No, it's correct. Which holds the mandate as a global coordinating authority for health. With its 194 member states, WHO brings united legitimacy and expand global presence, and the expertise required to empower countries and partners to advance health and well-being worldwide. However, to operate effectively as the backbone of global health, WHO requires two major enhancements. Increased core funding. Currently, about 80% of the WHO budget relies on voluntary contribution earmarked for specific projects, leaving little flexibility to respond to emerging health threats. Increasing core funding is essential for empower WHO with the flexibility to address pressing health issues as they arise without being constrained by specific donor interest. A recent decision on WHO funding marks an important step towards solidifying its financial basis. WHO also recently launched its first ever investment round for the 2025 through 2028 period. This innovative approach aims to mobilize sustained funding for the WHO core work, working not only for existing donors but also reaching out to attract new ones. For the WHO to effectively lead and coordinate during crisis, it must have stronger decision-making authorities by empowering WHO to make swift decisions which can facilitate faster, more coordinated global response in health emergencies. Reforms in governments are essential to give WHO the necessary authority to unify efforts across countries and other health organizations. The negotiations on the pandemic accord are an opportunity to strengthen WHO. And of note, it's impossible to actually accept that we have white spots in this world where countries cannot participate in the WHA or the WHO meetings. And I'm very proud to say that the German parliament passed a couple of years back a notion that to support Taiwan to be at minimum an observer at the WHA and WHO. I think that's very important because health is a global issue and not only an issue of several countries. Because the diseases do not have passports. Viruses do not have passports. Bacteria do not have passports. Effective global health governance also requires collaboration with other actors such as the United Nations, World Bank, and International Monetary Fund to address social determinants of health such as economic stability, education, and housing. A cohesive approach between WHO, the UN, and financial institutions can address both health and social economic factors. Such collaboration is crucial to building resilient health systems that can withstand emerging global challenges, including the complex impacts of climate change. The WHO Global Action Plan aims to improve coordination between aligning health agencies around country-led strategies. Although promising, its impact may be limited due to weak enforcement mechanisms. Revitalizing this plan could enhance alignment among organizations, enabling them to better support countries. By prioritizing collaborations, strengthening existing structures, and addressing inefficiencies, we can maximize the impact of each dollar invested in global health. Financing for global health. This is, of course, a big challenge for every politician in the Northern Hemisphere. The competition is about limited resources, and the fragmentation in the global health system has intensified competition for these limited resources. Funding is often spread across multiple initiatives, resulting in a traffic jam effect where numerous institutions are looking for the same donor contributions. With nearly all major concessional funds seeking replenishment in 2024 and 25, including IDA, Gavi, and the Global Fund, the financial strain is unprecedented, creating an urgent need to rethink our approach of financing. Currently, 4 institutions, namely the IDA, Gavi, WHO, and Pandemic Fund alone account for $48 billion in US dollars in requiring funds in the next 6 months. Unfortunately, this is happening amid the backdrop of reduced aid budget and adding to the challenge. If left unaddressed, many low and middle income countries will struggle with limited social sector spending, risking setbacks in health and other key areas. This funding traffic jam also brings to light critical questions about the structural stability and long-term sustainability of the current concessional finance network. Now it is the time for a bold reimaging of the system to better meet the evolving global needs. Moreover, we are witnessing a decline in core multilateral aid, with many donors increasing opting for bilateral rather than multilateral contribution. Since 2010, multilateral aid has dropped from 23% to 18% of total ODA, driven by skepticism towards multilateralism and inward political priorities. The global health landscape has evolved with the rise of thematic vertical funds. While initially focused on poverty reduction, recent years have seen funds centered around specific themes like health and climate. This shift has led to a surge of specialized funds like the Pandemic Fund and the Loss and Damage Fund. While each fund addresses emerging needs, they add to the strain on donor resources and contribute to a more competitive landscape. Despite tighter budgets, donors paradoxically continue to create new funds to address emerging challenges. For example, the past 2 years alone have seen the establishment of the Pandemic Fund and Loss and Damage Fund and the Livable Planet Fund. However, this also raises concerns about whether these funds will heighten competition for limited resources or bring in new contributors. In conclusion, the current global health financing scenario calls for strategic adjustments. Before creating more funds, we must focus on maximizing the effectiveness of existing ones, encouraging collaboration over competition. We must address health priorities in the resource-constrained world. We need coordinated planning and assessment of current fund overlaps and sustainable, innovative financing approaches. What are the strategic solutions for sustainable financing? And this is something we could think about. This is not a per se suggestion, but what about the hybrid ODA model? In light of evolving geopolitical challenges and criticism, the traditional ODA model, criticism of the traditional ODA model, several sustainable alternatives and complementary strategies have been proposed to make international aid more effective and relevant. These alternatives focus on integrating development with environmental, social, and economic sustainability, often involving new forms of financing, partnerships, and development approaches. Fragmentation between health and finance dialogues creates a gap in effective financing solution. A permanent coordinating body could bridge this divide by facilitating regular cooperation between health and finance sectors. Such as a platform would align policies, improve information sharing, and foster systemic engagement to create a more resilient, integrated health financing framework as depicted here in this picture. And it's obvious if you're losing some pillars, the instability will become obvious. We heard it today before. Public-private partnerships are increasingly crucial for closing funding gaps in global health. By pooling resources and expertise, PPPs can help driving solutions to health financing challenges. For instance, Gavi's collaboration with pharmaceutical companies for vaccine procurement demonstrates how these partnerships can improve efficiency and expand access to critical health services, particularly in underserved areas. Strengthening domestic health financing is essential for sustainable health systems, especially as dependence on external aid leaves health systems vulnerable to budget cuts and donor shifts. To achieve this, we must empower low and middle income countries to lead their own health strategies. Improve tax systems and public expenditure management can significantly boost domestic health budgets. Research shows that better tax collection could substantially increase health funding, fostering self-reliance and resilience. Now I got it right. To fully understand the disparities, in 2021, high-income countries accounted for nearly 80% of total health spending, while low and middle-income countries, which represent over half of the global population, disease burden, accounted for only 3.8%. Stabilizing and sustaining the financial basis for global health, a multifaceted approach combining innovative funding mechanisms, strong international partnerships, and commitments from both public and private sectors. Here are some ideas that I put up here on the board in bullet points, and I'll go through them very quickly because I think time is passing by very quickly. Innovative finance mechanisms like a global health bonds or debt swaps for health. Public-private partnerships, we did talk about this. Increased domestic health spending as strengthening domestic health budgets, but also efficiency improvements, for example, reducing waste and improving procurement processes can free up resources within existing budgets, especially in low and middle income countries. Global health insurance and risk pooling with a global health insurance scheme or catastrophic health funds. This would be an international fund dedicated to addressing global health emergencies such as pandemics that can be accessed by countries in crisis without jeopardizing their long-term health budgets. Multilateral commitment and accountability, digital innovation in health financing, strengthening local capacity and resilience, like training and retention programs for health workers, adapting to climate and population changes, meaning health system adaptations to climate change, and looking at population aging and non-communicable disease preparedness. And by combining these approaches and fostering global collaboration, the financial basis for the global health can be stabilized and made more sustainable, ultimately leading to stronger health systems, improve equity, and better preparedness for future health challenges. Coming now to more fostering collaboration and consensus, as demonstrated in the previous section, a fundamental rethinking of global health is essential. Health diplomacy is a crucial tool for this process, not only for reforming the architecture, but also for securing sustainable financing. It plays a vital role in bridging diverse national interests, setting common standards, and mobilizing resources to address global health challenges and affect motion. I got the message. Also, building consensus among diverse stakeholders, health diplomacy is particularly important in aligning national interest with global health goals. Stakeholders often have conflicting priorities, but skilled diplomacy can align these interests around shared goals like universal health coverage, health security, and sustainable health financing. Parliamentarians as health diplomats. Parliamentarians serve as vital connectors in the global health landscape. Through the platform like the Unite Parliamentary Network, they bridge national and international agendas, acting as advocates for sustainable health policies within their countries while championing global health commitments. And if you are interested to become a member of Unite, this is a small advertisement. Go to the website of unitenetwork.org, Unite Network as one word.org. Then you have more information about this network of parliamentarians worldwide, and we're all looking forward to you to become members of this network, because this I would call a grassroots network of parliamentarians in the global health architecture. And they are not only shaping domestic health policies, they also represent their nations in multilateral settings, dividing consensus on critical issues like AMR, pandemic preparedness, climate resilience, and their engagement in global health diplomacy exceeds beyond funding. It includes advocating for resilient health systems, equitable access, and alignment with global health goals. In conclusion, global health governments must evolve to address the pressing challenges of our time: pandemics or future pandemics, climate change, and health disparities. By reforming institutions like the WHO, strengthening coordination, and fostering health diplomacy, we can create a more resilient and equitable and adaptive global health system. We move forward. As we move forward, let us embrace this vision of reformed global health government structure. Together, we can build a global health system that addresses emerging challenges, promote health equity, and ensures that all people have the opportunity to lead healthy lives. Since Dr. Taters always says, health is a human right, and we should leave no one behind. Thank you for your attention.
Thank you very much to Dr. Uman, and would you please wait on the side and join us later for the panel discussion? Thank you. 那接下来呢是我们综合讨论的时间了。Thank you to all of our speakers on the stage. Thank you to Professor Keiji Fukuda for sharing some very impressive stories, both very personal and also impactful. And Dr. Fattenker, from his talk, we know that a good public health campaign can really make a difference. And also thank you very much to Senator Patterson for giving us a different kind of perspective into a global health diplomacy, which is a more security one. And also, of course, finally, we have Dr. Uman for sharing with us the future of global health governance and financing. 那非常谢谢我们刚才的这个4位主讲人哦，带来非常精彩的这个分享。And now we're going to move on to the panel. So we'd like to invite all of our speakers back to the stage and take your seats on the stage. And if you wish to raise questions later, please use the microphones at your seats, and please turn the mic off after you finish your question, and also let us know who you are before you raise your question. 那等一下呢也会开放提问哦。那各位贵宾要提问的话呢，都可以用您座位旁的麦克风。那提问完之后呢，请记得将麦克风关掉，才不会影响那个口译的这个讯号。All right, now and over to our moderator, Professor Liang again.
I feel that obligated to say something about the last talk by Professor Allman, and he actually addressed the issue of global health from an angle that I didn't think about carefully in the past. One is about the governance, the financing, and talking about the importance of the need of the involved governance, because the issues such as pandemic, climate change, health inequality, and so on and so forth are evolving. Also about the importance about the financing in order to address you have a stable financing. I think that we need to have the concept of the collaboration instead of a competition, and should have the set of priority to maximize the limited resources, and also to make the things sustainable. And this, so we mentioned about the multi-facet approach, such as digital innovation and so on and so forth. One thing I thought was quite interesting and good to hear at the end that the Professor Allman talking about the 7 dimensions of global health, diplomacy by Professor Bush, who was not here today, but I'm pretty sure she will be grateful to hear that some of the concept has been conveyed to the audience. So we had about a little more than 10 minutes. We'll open up for floor discussions. Any questions from the audience? Yes.
Thank you, Senator Dr. Stan Kuchar from Canada. Like all the panelists, there has been a recent global pushback against coordinated health diplomacy through the WHO. And certainly in our country, there has been a weaponized, populism-driven anti-WHO, anti-vaccine lobby, which has become very strong, certainly also in the United States and in some European countries. So how does one deal with this toxic populism and its anti-expert, anti-health lobby in the diplomatic area of health diplomacy?
Now it's working. That's a wonderful question. I think nobody really has the golden bullet up here to give you the right answer. Otherwise, we wouldn't be worried about your neighbor today, and just coincidental, of course. And we have the issues in Europe as well. It's an infodemic. It could be also a hybrid war that's going on with wrong information or obviously wrong information that's subtle, put into social media by geopolitical main players who do not appreciate democracy. I think that's an open secret that is happening, and it's like an infection. It's infodemics. It's contagious. People believe in conspiracies. They believe in all kinds of weird things, and the only way around, I would say, is to get the people empowered with good information. It's easier said than done, of course, but I have no golden bullet. If I would have the golden bullet, I would be probably the Chancellor of Germany, then have over 50% of the electoral votes. But we're not there yet. I think it's important that it is we have to be more resilient with education. It starts in the younger age. It's still a minority, but I do hope it will never become a majority. We had similar issues in my own country, in Germany, about almost 100 years ago. And that is really concerning to see parallels of history in part repeating itself.
I know you didn't really want another Canadian responding, but I think I will. So this is, as we say, it's a complex and wicked problem, but this is where we have to, you can't really find the root cause, which is why we don't know where it originated. But I was reading a political science paper, and they talked about this kind of, single issue extremism, a salad bar extremism. You're really mad at the salad bar, but it might be the cucumbers. And what people like this can't do is attach their discontent and their rage to something. And when I look at our Canadian experience, as senators, we have complete, the public has access to email us. And, we probably get 100 emails a day on form letters to abolish the World Health Organization because it's going to take away, and this is the root here, our democracy, our choice, our sovereignty. So again, we know what the output is of it, but I have to admit, we had a conversation yesterday with our Taiwanese friends in the Ministry of Health, and they actually talked about having institutions to look at this disinformation. I mean, I'm not talking about letters to politicians. What I'm talking about is the, almost cancerous spread of this anti-World Health Organization. And while we recognize it probably needs reform, it's saved millions of lives just trying to collaborate what we're doing. So I think that even collaboratively good practices at, yes, freedom of speech, but looking at how we control our media and control access and having a counter-narrative. Because if you were to ask the average Canadian what the World Health Organization is, they, A, would glaze over, but secondly, they would go to what they'd heard first. So having a look at sort of a downstream approach is going to be quite important. I was quite interested in what Taiwan is doing. And then, of course, how do we get at the root? Receiving the disinformation and educating our populace on how to effectively use what we're reading.
Professor Fukuda?
Just to add to the comments of my colleagues, I think there are two observations that I'll put on the table. One of them is that what distinguished the response to COVID from every other pandemic and large outbreak response I've seen is that heads of state had a disproportionate amount of direct involvement with decision-making on the pandemic. And as a consequence, what we saw was a lot of country-by-country decision-making and much less of a uniform decision-making. So there's been a lot of attention on whether WHO or the IHR can turn this around. I think that's very difficult because I think the root issues were not in the IHR. Second issue is that I think that it's simply a fact that we're going through an era in history in which populism and isolationism is a quite strong movement in a number of different countries. And when I look at these two things together, I think for me, a disproportionate amount of what's going to have to be done to address the kinds of issues that you're raising is really on the domestic front. I'm not quite sure that anything internationally can be done because that in and of itself is going to be cause for resistance for people who don't like vaccines and so on. And I think that the domestic work really is going to revolve a lot around education, how the divides between the two sides are bridged, and what is it that's going to bring it together. As you may know, I come from that country in which we're all waiting about the election results, and this is very much the discussion which is going on.
Opinion to tomorrow's talk. I'd like to have maybe one more question from the audience. Yeah, Dr. Chu.
Thank you, Chairman. I am Betty Chu from National Health Research Institute, Taiwan, of course. Okay, I have one quick comment and one suggestion for Dr. Andrew Woman. Yeah. When you talk about two things, I think you are the most handsome man in the whole world. The first thing is when you talk about disease or microorganism doesn't have a passport. Excellent, excellent quote. And then the second thing you mentioned about in your Germany parliament, you have a platform. It's called Unite. Unite.
That's an international platform. It's not a platform within the parliament.
Right, and you also talk about to bring Taiwan parliament in. Wonderful, that would be wonderful, because I think this Unite organization really sets a very good example and can be a very good role model for all the parliaments, including Taiwan. So my quick suggestion for you is please stay longer in Taiwan and or at least let us share your speech or today's material to Taiwan parliamentarian, because they really need some education about global health and global health diplomacy and global health governance, and really understand the importance of finance and all these kind of funding things. That would be wonderful for Taiwan. Thank you.
I have to say thank you, too, because there were so nice words. This feels so well, because just talking about what we heard before, I had an email just a couple of minutes back. I should be kicked out of the parliament because I think that vaccines help to prevent disease. And these are emails that I get tons per day. And which we're talking about disinformation problems, which is psychologically a psychological war against parliamentarians. That's why your words were kindly appreciated. Just one word to make sure: the Unite is an international platform, not by the German parliament. We have a subcommittee on global health in our German parliament, and we passed the notion on Taiwan to be a minimum observer at the WHA and WHO. Just the slight difference, and I'm happy to share my slides. I have no idea how we could do this. I will ask my office when I'm back to Germany. I have to go back tonight because we are in a slight crisis with our coalition, and there are some bigger issues that have to be one of the parliamentarians to be at presence and not in Taiwan. I would love to stay longer, to be honest. It's a lovely country. Thank you.
Well, as the moderator, I hope you notice that I've been trying to be fair for all speakers. I like to think that the two speakers from the left side are quite handsome as well. Definitely. Yeah. Something we... It's all right. So maybe, I think we're running out of time. In closing, a personal remark, if I may. And I've been attending the WHA meeting in May in the last 3 years. And one thing I found which I found very cynical, is that the theme of the WHA has always been health for all. But is that the case? We all know the answer. I think this is one of the reasons why I think that we organize this section, hoping we'll get some advice from you, all of you, sharing with your experience as how we can make a better, as a good citizen to the world by contributing what we have experienced, what we can offer to the rest of the world. I think that it's been very, very helpful to listen to all of you. But I also want to reiterate the commitment from our government by working hard and by making contribution to promote the global health for the world. So please join me to thank our 4 speakers again. Okay.
Thank you very much. And can I have all of you come to the front? It's time to present the certificates of appreciation, and Professor Liang will be presenting the certificates on the behalf of the organizer. Okay? 我们的证书呢? Okay? All right? 有请. 可以出来咯. And now, firstly, to Professor Fukuda. Yes, Professor Fukuda, would you please join us at the center of the stage? Thank you so much to Professor Fukuda Keiji. And next to Dr. Bernard Fattinger. Thank you so much for your presentation. And next to Senator Rebecca Patterson. Thank you so much. And last but not least, the handsome guy, ladies and gentlemen, Professor Dr. Andrew Ullman. Yes. Okay, give your speakers and moderator another big round of applause. Thank you so much. That's it for this session, ladies and gentlemen. Next, we're going to do a 15-minute coffee break. We have refreshments and also coffee and tea ready outside. Please help yourselves, and we'll be back by 3:20 for another plenary session. Thank you. 各位贵宾，接下来呢，我们稍微休息一下哦。我们在场外呢备有茶点以及饮料，请各位贵宾呢自行取用。等一下3:20，3:20呢，我们再次回到会场，谢谢。
our leadership has been pivotal in advancing health policy dialogues across Europe, and his work on digital health policies offer valuable insights for international health cooperation. Professor Auer started his careers as Austria's leading civil service in the public health system in 2003. He has played a central role in all major health reform measures in Austria, including the reimbursement system for medicines, the establishment of a new market authorization agency for medicine, and a new national public health research institute, numerous reforms in the area of the social health insurance. Particularly from 2018 to 2022, he served as a member and the vice chair of the executive board of the WHO in Geneva. During the COVID-19 pandemic crisis, he was the national coordinator in Austria and a co-chair of the joint procurement board of the vaccines for 450 million European civilians. So since the 2018, Professor Orr has been a president of the European Health Forum Guesting. In 2022, he took on a position as WHO Euro representative in the advisory board of the WHO Kobe Center for Health Development. I'm very confident his speech will inspire the new ideas and foster the cooperation through the Digiplomacy. Ladies and gentlemen, let's welcome Professor Auer.
Thank you very much for the kind introduction. For the academician in the room, I'm not a professor. I'm just a simple, or used to be, just a simple policymaker. But thank you very much for inviting me again to Taipei. It's always a pleasure to be in Taiwan, and as I always say, you can learn so much to be here in these wonderful countries. Ladies and gentlemen, dear friends, dear colleagues, I would like to ask you something. Everybody attending this conference has a professional background in health. And I want to ask you this. Why are we working in the health sector? Why are we dedicating our life to this enormously important part of our societies, this core function of public infrastructure in the countries in which we live, in the countries we call home? Medical doctors, you might say, I want to cure sick people, to save their lives, to make them happy again, to relieve them from suffering by applying science as well as the experience, the tools, and the art of healing that I have at hand as being a doctor. As a nurse, you might say something very similar. And the political scientists and lawyers in the room will also say, yes, we want to make our societies a better place for the vulnerable among us. We want to make healthcare systems a fairer place to which everyone has equal access, regardless of class or income. Nobody should be left behind when it comes to treatment of the sick or to the prevention of harm among the healthy so they don't get sick. This is what motivates us to dedicate our lives in the healthcare systems and in our respective jurisdictions, in our townships, in our regions, countries, or on the multilateral level among nations. Our shared goal is health and well-being. And we all want to make sure that we help people regardless of the role and occupation we are in, regardless of whether the services we provide are digital or analog. And we want to make sure that all of society shares the burden and the risk of being ill. Shares the burden and the risk associated with means and costs of healing diseases. I guess we call that solidarity, the value which tells us, yes, we do owe each other this mutual assistance, this mutual help. We do owe each other support systems which care for us. Ladies and gentlemen, friends, why do I ask you this question? My answer is very simple. Health and the well-being of a society requires solidarity. And solidarity can only develop in a society of trust. It's all about mutual trust. And mistrust is poison, which undermines the spirit of solidarity. I guess we all agree that we're currently experiencing a time of mistrust rather than trust when it comes to our national or global politics and the public discourse in our societies. A daily look at the media or the digital world of social media gives us a good understanding of how far-reaching these threats has already become for free societies, democracies, but also for mental health and well-being. We live in times of political divisiveness, and culture wars. And that is exact the opposite of what we strongly believe in this room. We believe in solidarity, health and well-being. Otherwise, we wouldn't be attending this conference. My first message is the digital means of spreading fake news, misinformation, divisiveness, and the feeling of fear and hatred is undermining our efforts to create healthier and better societies and must be taken very seriously. False and misleading content online poses significant risks for the well-being of people in society. While such content is not necessarily illegal, it is harmful because it contributes to political polarization, reduces trust in democratic institutions, and negatively impacts fundamental human rights. The internet has become the primary conduit for spreading false and misleading content quickly and on a large scale. The dissemination of false and misleading content online has played a prominent role in many recent crises, for example, in political elections around the world, the COVID-19 pandemic, or Russia's war of aggression in the Ukraine. In a recent Truth Quest survey, we learned that, on average, only 60% of respondents were able to identify false or misleading information. So 40% didn't get it. No? Satire, interestingly, was the easiest type of content to identify it as false at 71%, followed by disinformation, 64%, and propaganda, 58%. Misinformation, 54%, contextual deception, 56%, and true content, 56%, were more difficult for respondents to correctly identify. And these numbers are even lower when the primary source of news and information is solely social media platforms. We should remember what horrendously negative effects false digital information had on the COVID vaccination drives in many countries around the world. When people that were fed rumors and conspiracy theories started to believe that we, the so-called health elites, were trying to embed chips in everyone or to purposely harm kids. My latest observation in that regard, in a member state of the European Union, a country very close to Vienna, a deputy of the parliament is currently trying to propose legislation to ban all persons who got mRNA COVID vaccines from donating blood. Why? Because mRNA vaccines might have, he says, a negative effect on the fertility of man and therefore might pose a danger to national security. The sad story is, by the way, the guy is a medical doctor. The sad story is that this proposal is taken seriously by some high-level politicians, like the Prime Minister of this country, and it might even put to a vote. My second message is trust must be developed, must grow in communities. And it doesn't matter whether the means organizing the relationship between the members of a society are analog, face-to-face, or digital via the many instruments of digital communications. But it is our role, our obligation, yes, our duty, to call for a renewal of the social contract for health and well-being in our societies, to renew our understanding of the principles of solidarity, our understanding that we owe each other social responsibility. The renewal of social contract for health and well-being is necessary because in the last 20 or so years, another paradigm has gotten stronger and stronger. It is a paradigm of borderless economic competition and global consumerism. The ideal of social cohesion and the need to operate our economies embedded in the vision of a social market economy faded. And the social and economic divide in our Western societies widened instead of narrowing the gap. This is the core reasons why we see this mistrust, anger, and hate growing. A growing proportion of people in our societies are feeling left behind with the consequence of increasing political radicalization. Building a societal consensus on the principles of solidarity is the only way to counterbalance the many voices out there which only wants to spread division, fear, hate, and the negativity of culture wars. I call upon all of us here to be part of such a strong, loud, and meaningful public discourse before it's too late and the negative voices prevail. And I deeply hope, as many of us here in the room, that we will not stumble into a new round of negativity when we find out who has won the presidential election in the US. To make the topic at stake a little bit more tangible, let me talk about my personal experience in politics, diplomacy, and global health when it comes to using either analog or digital tools in communication. As a long-time Director General of a National Ministry of Health, and as someone who was successfully involved in multilateral policies at the level of the World Health Organization and the European Union, I have concluded that the relationship in those contexts are not different than in a family or in a community. Without mutual trust and respect, you cannot produce any concrete results towards achieving healthier lives and a sense of well-being for all. Again, mistrust is a poison which undermines every good intention in that regard. Yes, you can use modern forms of communications in diplomatic or bilateral negotiations or endeavors. In 2020 and 2021, I co-chaired, as my introduction already mentioned, I co-chaired the board of competent authorities in the 27 member states of the European Union in charge of purchasing the COVID vaccines for the 450 million Europeans, EU citizens. As you can imagine, this was one of the most challenging tasks of my whole professional career, given all the circumstances and the enormous political and public pressure we faced back then. In those times, we met exclusively online via video calls and successfully negotiated highly complex purchasing agreements between the European Commission, the 27 governments, the companies, the pharma industry, and all other parties involved. We were in contact with each other almost daily, even when we were on holidays. And all that we saw of each other were the stamp-sized faces of each other on our screens. But the key to this success story was mutual trust, because most of us already knew each other and were convinced that we shared the same strong political goal to end the pandemic threat. We acted on behalf of health and well-being. And we succeeded in purchasing many hundreds of millions of doses of vaccines to make life possible and safe again on an individual and a public level. And I still feel good about having helped to prevent millions of deaths throughout Europe. And we did all this exclusively with the digital means at hand. Since travel bans have been imposed, I even have to say that without e-diplomacy, without the means and the help of digital tools, we would not have been able to achieve anything in this regard. During the same COVID crisis, I had a totally different experience working at the level of the World Health Organization. The lack of mutual and political commitment among member states made it impossible to effectively implement COVAX, the program to ensure that everyone had equal access to vaccines globally, and not just people in the club of the rich OECD countries. From the very beginning, this whole topic was undermined by mistrust. To start with, industry had totally unacceptable ideas about pricing. In the beginning, industry was not willing to give up intellectual property rights or to share and transfer the technology with other potential producers, especially those in the global south. These limitations of production capacities in the global south made it impossible to give fair access to everyone, and meant that only the industrial high-income countries had exclusive early access to vaccines. These limits in production capacity and the need to satisfy the demand in Europe and in North America prohibited the early sharing and distribution of these life-saving vaccines. The point in this story is, without the ways and means to negotiate in an analog face-to-face setting, where you can step over lines of divisions by speaking confidentially outside the conference rooms, the whole COVAX endeavor was unable to develop its full potential and remained only a fragmented success, and our friends in the global south know what I'm talking about here. My third personal example to understand digital or analog means of diplomacy is about the governance structures within the World Health Organization. Back then, it also was already mentioned, in 2020-21, I was a member and even the vice chair of the executive board of WHO. And I was a member of one of the two major governing bodies of this organization. And I must tell you that after the official announcement of COVID as a public health threat of international concern by the Director General of the WHO, it took 9 months for the executive board, the governing body of the World Health Organization, to start discussing the enormous political implication of the pandemic. 9 months after the official declaration. And I would guess you agree with me that this is not an effective governance structure for this important organization. So the Director General Tedros and I agreed on the urgent need for improvement. My goal was that within 24 hours after the DG of WHO announces a special committee of the executive board must be convened to determine political or a potential policy implication for member states and the whole organization. With these policy implications, I mean not so much a question of science in the context of a pandemic threat. Policy implications of this type can mean a reshuffling of funds within the organization, the appropriateness, for example, of travel bans, etc., etc., etc. Why do I say this? I spent months building trust and commitment among member states, arguing that the establishment of a new governance structure of this kind would be in the interest of the member states. I eventually succeeded and the governance structures were changed. But that was only possible because I established and cultivated personal contacts with the partners to convince them to share this common goal. By the way, this committee is working and it meets not regularly because we don't have a fake all the time, but they meet online and face-to-face, let's call it hybrid diplomacy. These and a host of similar examples of health diplomacy show that building trust is crucial to achieving results. E-diplomacy only works if there is already a pre-existing level of mutual trust. And if you have to start from scratch to build trust, then you definitely need the old-fashioned approach of sitting down face-to-face and talking over the issues at stake. Otherwise, the multilateral level of health policy remains nothing more than a discussion club, all talking without any action and change to make things better in the interest of the citizen. In so many cases, the lack of successful multilateral action feeds into a new digital phenomenon, fake news and the instant spread of purposely incorrect information, like saying WHO is an illegitimate world regime led by a small elite who are taking away regular people's personal freedom and rights. As a member of the executive board, I was targeted by thousands and thousands of emails and personal threats telling me to give up on supporting the pandemic agreement currently negotiated among the member states. This campaign was based on misinformation, fake news, and the mindset that opposed rational science and multilateral cooperation. All of this was fed by rumors and conspiracy theories spread across the internet and social media. I survived these campaigns, no question, but it shows how far these attempts of digital pressure have already progressed and how they can have negative effects on rational decision-making. What I want to say in the context of this conference is the following. We, the participants in this conference, are committed to health and well-being. We know how important trust is on all levels of services we provide for a better life. We also know from the experience of the last COVID crisis that fake news breeds mistrust, unfortunately, also increasingly at the level of political decision-making. Therefore, with all the opportunities of modern global digital communication, trust can only be built with a never-changing discipline of good practice in politics, which I would summarize as follows in paraphrasing Reinhold Niebuhr: having courage to change what must and can be changed, the serenity to accept what cannot be helped, and the insight and wisdom to know and distinguish the one from the other. Thank you very much.
Thank you so much, Professor Orr. Thank you for his unwavering sharing the experience regarding the trust. We can understand the hybrid diplomacy can only work under the trust and the respect. Thank you, Professor Orr. Next, it's our great pleasure to introduce our next speaker, Dr. Jianzhang Li. Dr. Li assumed the role of the Chief Information Officer for the Taiwan Ministry of Health and Welfare in 2024. As CIO, Dr. Li oversees the information technology systems and the security activities for a workforce exceeding 5,000 individuals. He spearheads the development and the implementation of the IT policies, manages critical projects, and strategically guides the IT investment, aligning with the Ministry of the Health and Welfare's mission to advance the health and the well-being of the Taiwanese population. Before his role as the CIO in MOHW, Dr. Li served as the Deputy Director of the Center of the Intelligent Healthcare at the National Taiwan University since 2020. In this capacity, he provided the strategic direction for the integration of the artificial intelligence into the clinical setting, offering expertise in policy development, budgeting, innovation, and risk management. Particularly, I want to mention his reward. Stanford University recognized Dr. Jianzhang Li as one of the top 2% scientists worldwide from 2021 to 2023, reflecting his prolific publication records comprising 250 scientific papers, over 11,000 citations. Today, he will share the experience how the Taiwan using the information technology to improve the efficiency and equality as well as the global health. Let's welcome Dr. Li.
Thank you for Director Xi's kind words. And actually, he's my noble person in my career. He's the man who introduced me to the government work. I really appreciate it. Yeah. And welcome all the distinguished guests from all over the world. Yeah. Today, I'm going to share some experience of Taiwan, how to unify the healthcare information systems. Which is, I think, is extremely important for the health equities. So, in our modern medicines, you cannot do anything without information system, from diagnosis, from your treatment, from prescriptions, from preventive medicines. However, the current situation is that different healthcare systems, different hospitals use different information system. So imagine you are using a PC, but everyone does not use the Windows. Each one of you use different type of operation system. What a miserable world we will live. So this is the current situation of our hospitals. Each hospital use different operation systems. So the information between different hospitals just cannot talk. And this will, if you are rich people, you're affluent people living in the urban area like the Taipei, you can care, your health care will be taken care by the receive your health care in only one elite university hospitals. But you live in a remote area, underserved areas, you probably have to have lots of a transfer if you have severe diseases. So this kind of diverse operation information systems will mostly affect those underserved populations. In Taiwan, Director Xi of the National Health Insurance create a what we call the My Health Bank. So although we use different information system for different hospitals, Taiwan citizens can download an app. And this app have their discharge summary, their lab test, their radiology report, so that although they visit different hospitals, they can show this data to the doctors. And also we have what we call the MediCloud. This is the cloud system that pull everybody's data together. However, this data can only be read by human. It cannot be read by machine, because although they pull together, they use different format. So the computer cannot interpret this information. This kind of system is already has a lot of effect on current modern care, but it just cannot be interoperable in different hospital information systems. So we want to modernize all of Taiwan's electronic health records. So we start to define what is the next generation electronic health record, what kind of features can define a next generation electronic health record. So finally we get conclusions. If you qualify a next generation electronic health record, you probably do have three main features. The first feature is called a FHIR. FHIR is a format that everybody's health record should be recorded in the same format. And this international standard is called a FHIR. And real library actually is that, for example, in Taiwan, every hospital have to report their claims to the National Health Insurance. And there's only one rule, but because different hospitals use different systems, they have to write their own programs to report health claims. But if we have this kind of rule libraries, so all the rules are deposited in this rule library, then every hospital can download the rules to do the health claims report. So this is called a rule library. We want to set up this kind of function to increase the efficiency of healthcare operations in Taiwan. And the third feature is called a Smart on Fire. It is a marketplace for the app, like our Android, Google Play's marketplace. We want to use our hospital information system. It's just like use our mobile phones. We can download the app we like. We can replace it when we do not like it. So this is our criteria for the next generation healthcare EHR in Taiwan. So, but Taiwan has different levels of hospitals. So we set up different strategies to reach these goals. So there are 22 medical centers in Taiwan. They already have very sophisticated, very complex information systems. So it is impossible that we use one system to unify them. Yeah, because these systems are closely related to their workflows. So the cost to change information system in medical centers is so high. So our strategy for the medical centers is they send the data to data servers and transform into a unified format, and then everybody can talk with each other. So this is our strategy for medical centers. For regional hospitals, their system is already decades old, it's outdated. And in Taiwan, about 300 to 400 small hospitals use EHR systems from 3 or 4 very small vendors. And these small vendors does not have the capacity to build a modern electronic health record. So our strategy is that to leverage the government's rich resources in the IT stuff. We have a research institute called the Industrial Technology Research Institute, which have lots of engineers. So we will create a platform to help these small vendors to upgrade their systems. And for the bottom of our Taiwan's healthcare pyramid, it's called the community public health stations. Actually, it's run by the government. And these health stations take the major role as the primary care. They do the preventive medicines, chronic disease management. Also, they have lots of public health missions. And their system is 2 decades old, so we will provide a new simple EHR system based on the open source system. So let's start with the medical centers. So this is we call the Taiwan Core Data Element for Interoperability. We announced this standard in September. So that means we require the 22 university hospitals have to record their health data in the unified data format of these 109 variables. So we call this data set Taiwan Core. Because we cannot unify all the data overnight, so we have to select the core set of the data set, started a unifying process. And in the past, you can create a new data using a new format. But how about the historical data? The large volume of historical data, if you want to unify the format of all this data, you will take large of labors. I mean, it is even thought as impossible. But with the current large language model technology or the natural language processing technology, we can do this kind of data transformation in a semi-automatic way. So the government collaborate with the ITRI, the Research Institute, to create a tool. This tool can help the hospitals to unify their data. There are 6 major steps. The first step is upload and processing. Second is to process the unstructured data. And third step is convert to FHIR data format and storage, validation, and transmission to next hospitals. So after these 6 steps, the data from hospital A can be used in hospital B's different hospital information systems. And one of the key steps in this process is the what we call the data ETL process. ETL is the extraction, T is the transformation, L is for loading. So if you want to use the staff coder to read every electronic health record and give each terminology, each diagnosis a new code, you will take lots of time and efforts. But currently, you can use LLM. LLM is the technology like the ChatGPT, so they can read the text and code them in the international standard semi-automatically. The accuracy is as high as 80%, so it saves a lot of labors. But it still needs the human to do the final verifications. So our tools actually have trained this kind of a large language model for Taiwanese hospitals' use. So with this, so the government role is to standardize this tool. And every hospital will try to use this tool for the health information exchange between different hospitals. And we also can use these tools to send the patient essential Taiwan Core data to a database, what we will call the My Health portals. So My Health portals will, based on the current MediCloud and the My Health Bank's foundation, but more diversity and recorded in the international standards. And we also use these tools, can standardize different hospitals' electronic health record so that they can use one rules. So these rules can be used for the prior authorization in health insurance or the cross-hospital quality management. And also, if you use these tools, the data has been standardized. They can be connected to the marketplace for the app. So all the AI applications can be put on this market, but different hospitals can use these tools to connect to this marketplace so that the ecosystems can be found. And the smart actually he's also one of the speaker of tomorrow's seminars as is Ken Mendel from Harvard Children's Hospitals. So he come to Taiwan to collaborate with us to develop the AI ecosystems for hospital information system here in Taiwan. And this standards has been endorsed by lots of US government or like a tech giant like the Amazon, Microsoft, and Google's, and a lot of academic institutions. So this is why that we choose SMART, our standard, to develop our application ecosystems for the hospital information systems. And this is what the Smart App Gallery looks like. There's already hundreds of apps in these areas, and many of them are open source. They do not have free of charge. So with this kind of open market, it will increase the global health equities. Yeah, it will not cause the digital divide. And so we already sponsor 3 centers in Taiwan to do a pilot project. These 3 medical centers will do the collaboration to make sure that these tools work seamlessly in different hospitals. And they also have to demonstrate that the data conversion can be conducted in the batch-to-batch continuous fashions. And they also have to demonstrate after the conversion, their data can connect it to the rural library and the smart marketplaces. And also they can aggregate data to send it to the My Health portals so that every citizen of Taiwan will have a portal to check their health data from different hospitals, and that is recorded using an international standard. And finally, they have to demonstrations to ask the seed teachers to teach other hospitals in Taiwan how to use our standardized tool to standardize their health record. Doesn't work? Are there any? Okay, good. Okay, so, but the second tier of our hospital is called regional hospitals. They are non-teaching, non-university affiliate hospitals. And we want to build a common digital platform to upgrade their systems. Because the government role is not build a new system so that a small company cannot survive. We want to help them to keep their EHR business in Taiwan. So we start to invent how to do this. Then we think of the Android systems, The concept of Android is like this. They have platforms, and each different mobile company, like Sony, like Samsung, or like the ASUS in Taiwan, can use Android to develop their own user interface to their customers. So we want to introduce this concept into our hospital information systems. So we want to build Android of the HIS so that different small EHR vendors can use our platform to develop their own electronic health record to serve the different purpose, to serve a different need, of different size, different purpose of the hospitals. So this is this platform we call the PAW is a platform advancing unified healthcare. So we were built using the several modules. So in the past, like a Google or Microsoft, they built a big platform using one company. But in Taiwan, the unique feature is that we have lots of medium to small companies. So we want to use the supply chain models that each small company builds one small modules, and the industry technology research institute will integrate them together. And this platform will open to the medium to small company of Taiwan so that they can use this platform to upgrade their current electronic health record. And this is for the community health stations. Actually, there are hundreds of this kind of stations across Taiwan. They can be in the mountains, in the remote areas, and they are very, very important for the peoples in the underserved areas. And they provide outpatient service and also lots of public health missions. And they care from the newborn to the elderly. This is a whole life care to provide lots of different public health tasks. However, their system is outdated. They are decades old, and they are fragmented vendors. And lots of public health reporting is still rely on the manual entries, and there's no integration with the telemedicine or the Gen AI. So we want to build a full function system for them because their system is relatively simple. And we do not, in the current day, we do not have to build the system from scratch because there are some open source, very high quality systems. One of them is called OpenEMR. This system is even certified by the ONC of the United Government. But we use this kind of open source systems have to be localized because many of the workflow is not compatible with Taiwan's health stations. So we will make a BlackBerry versions of these OpenEMR systems and make them available, make them used for every Taiwan's health stations. So this is our current strategy to unify our electronic health record system and to promote the digital health equity in Taiwan. And we'd like to share this kind of experience for our friends from all over the world. Thank you.
Thank you, Dr. Li. He demonstrated the recent advancement about the health information system reform in Taiwan. It sounds so prospective and promising. Okay, thank you so much. Next, I would like to welcome the next speaker, Professor Milon Anthony Godino. Yeah, here. Dr. Godino is a research fellow at Westmead Applied Research Center, University of the Sydney. He is also associate fellow of the Higher Education Academy and the secretary of the Digital Health and the Informatics Network at the University of the Sydney. His research focuses on the global progress toward the universal health coverage and the health equity issues. He worked at furthermore he worked at WHO collaborating center for e-health at UNSW from 2018 to 2022. He conducted the digital health research projects for the WHO Western Pacific region office and the Asia Pacific Observatory, which informed the international agenda setting for policy making in global digital health. His work is among the first to explore the novel area of the digital health diplomacy for facilitating the global socio-technical interoperability required to integrate the systems. So I think today's his sharing and the speech will help us understand how the health diplomacy can address the health disparity on the global scale. Ladies and gentlemen, please join us to welcome Professor Godino.
Hello? Right. Very good afternoon to you all. I have the unenviable task of trying to keep you all awake pretty late on a weekday afternoon, so bear with me, and I appreciate the fact that you are all here today. So today's talk will be on Taiwan's digital health diplomacy. I'm just going to present some of the research that we've done. This started off as a side project during my PhD. Anyone who's done a PhD knows that it's very tempting to get distracted. And my supervisor gave me a very long leash. And so I started exploring this concept of digital health diplomacy and how that might sit within what we've already heard about today earlier, which is global health diplomacy. So let's have a go at trying to unpack that a little bit. And I've just shut it down. Sorry. Can we get the slides back up? Go back. Okay, right. So really quickly today, we'll talk a bit about what digital health diplomacy is. We'll look at some work that I did on looking at regional and global diplomatic conferences, which topics were discussed, and what exactly that looked like from a digital health perspective, but also from a diplomacy perspective. Because remember, there are two groups of stakeholders that are interacting here, each who have their own agenda. A diplomat's agenda will be very different from a digital health expert's agenda. And I think that previous presentation, which is quite difficult for me to follow in the wake of, I have to admit, is going to try and make that very clear, how diplomats in digital health look at this very differently. They will then look specifically at some examples of Taiwan's digital health diplomacy, and then I'll try and relate that to the different dimensions of digital health diplomacy that I will unpack as we go on. Sorry, just trying to get it to go to the next slide without shutting down, hopefully. Okay, so first of all, I think this might be an older set of slides. We've got the concept of digital health diplomacy. What exactly does that look like? Is it digital health as applied to diplomacy, or is it digital means being applied in health diplomacy? Now, this is somewhat a technical difference, and I think as we'll unpack this, this will become clearer. But these are two different discourses, and they're not exclusionary. They're both part of the same picture. Digital health diplomacy is what occurs when you have digital health stakeholders coming together with diplomatic stakeholders to try and address set objectives. Based on the Madrid Declaration of Digital Health, of Science Diplomacy, we can infer that there are 3 dimensions of digital health diplomacy. The first one is diplomacy for digital health, which is using diplomatic means to achieve digital health objectives. One example of this is, for example, during COVID-19, we saw that countries cooperated diplomatically to institute the use of digital vaccine passports, with the EU's diplomatic efforts in this regard culminating in the WHO's Global Digital Health Certification Network. That is an example of diplomacy being used for digital health. Second dimension, digital health for diplomacy. Digital health is used as a means to achieve diplomatic objectives. Another example here from COVID-19, as health data became essential for COVID-19 response, cross-border health data sharing became a signal of diplomatic trust, while delayed or incomplete data sharing bred diplomatic strife. And we've unpacked this in that paper reference that you can see at the bottom. But some of you may remember specific instances from during COVID-19 when people refusing to share health data became a significant source of diplomatic strife. Lastly, the third dimension is digital health in diplomacy. And this is a case of digital health informing foreign policy. So, as COVID-19 drove the adoption of digital health, cybersecurity breaches positioned the cybersecurity of health data as a focus of diplomacy. So, as you can probably see from here, digital health diplomacy has several conceptual overlaps. It does touch upon science, tech, and innovation diplomacy, or STI diplomacy, but it also engages with data diplomacy, global health diplomacy, cyber diplomacy, AI development, knowledge diplomacy as well. At the global level, digital health diplomacy occurs at the WHO. We all know much about the resolutions on e-health, digital health, and following that, there was the National E-Health Strategy Toolkit. That toolkit put out this framework, which comprises of 7 components, and almost all digital health policy that has been made can be mapped to these 7 components. The most recent document in this regard is the Global Strategy on Digital Health, which came with 4 strategic objectives. That is to promote global collaboration and knowledge transfer on digital health, advance the implementation of national digital health strategies, strengthen governance for digital health at global, regional, and national levels, and advocate people-centered health systems enabled by digital health. So let's just keep our eyes on these 7 components and look at how these components are fleshed out at various levels. So we did an analysis of selected diplomatic meetings. The methods that we used for selecting these meetings was that they had to specifically mention digital health within the policy meeting outcome documents. They also had to specifically address either at least one of the 7 constructs that we include over here that you can see at the top of the table. And these are the WHO ITU National E-Health Strategy Toolkit Framework Dimensions. We selected the meetings also because this is the first research that we know of that looks at the concept of digital health diplomacy in this context. An example of intra-regional digital health diplomacy, sub-regional digital health diplomacy, interregional, intra-regional, and trans-regional. And these are just different groupings of of how many countries and in which regions those countries are located when trying to cooperate on digital health issues. So for example, we saw in the Assembly of the African Union, we looked specifically at the African Union CDC's documents on digital health transformation. And we saw that there were specific flagship initiatives, for example, that addressed each of the framework dimensions. There were specific policies that were put in place and specific strategic objectives that mapped directly to the framework dimensions. At the Pacific Health Ministers meetings, I was very fortunate to actually be there in person for this in Fiji last year. And the meeting documents and the outcome documents specifically addressed, again, the framework dimensions with a specific emphasis on infrastructure and capacity building for the workforce. We also looked at documents from the ASEAN-EU dialogue. This was our only example looking at inter-regional DHD, or digital health diplomacy. And here we could see that they were taking a much more strategic approach, looking at areas that ASEAN and the EU could actually cooperate on. based on the amount of development that they had going in those areas. And that typically focused on strategy and investment, legislation, policy, and compliance, and to some extent, services and applications as well. At the G20, that was hosted, I think, last year, the Indian presidency, is where they focus mainly on digital public infrastructure, and this specifically focused on infrastructure and standards and interoperability as far as enterprise architecture was concerned, and building the software and the digital architecture that would be required for digital health infrastructure. Okay. Right, so here again we selected specific examples of digital health diplomacy as conducted by Taiwan. And what you can see here is that there are two distinct types of meetings that we saw. We saw that there were multilateral meetings, and this is Taiwan engaging specifically with a multitude of countries, or there were bilateral meetings that were inter-country. There were also, these also typically mapped to the, there were two different groups of stakeholders involved. So the first two meetings that we saw specifically focused on digital health stakeholders, and the last three in that table specifically focused on country stakeholders. These were typically diplomatic objectives as opposed to digital health objectives. So for example, with the HIMS meeting, they focused on cybersecurity, resilience, workforce development, digital capacity building, and AI. And there wasn't too much discussion of the diplomacy-related discussion themes. The APEC policy dialogue, this is held in 2022, was co-located along with APAMI and AHIN 2022. And here you could see a discussion focused on interoperability, health data security and privacy, national e-health strategies, governance, enterprise architecture, standards and interoperability, program management, and people. The diplomacy-related topics that were discussed were that of regional integration. A quote that I particularly liked in this regard was that they recognized the purpose of the meeting was to jointly address wicked problems that no country is in a position to tackle in isolation, no market or EMR vendor has an incentive to tackle, and no vendor consortium developed technology standard is equipped to handle. The purpose of meetings like this, where you have co-located diplomatic stakeholders, along with digital health stakeholders, based on what I've seen, is actually quite rare. So this is something that I would like to impress upon you and emphasize and discuss later in future slides. The country-focused initiatives were UK-Taiwan, Taiwan-Czech MOU, and the Canada-Taiwan MOU, and these are typically bilaterals. The digital health topics here were health insurance, partnerships for reconstruction to assist Ukraine in primary health care, and then international health security, of course, Taiwan's health insurance system, as we've already seen today, and electronic medical records. The diplomacy-related topics typically focused on information sharing and exchange, and institutionalizing cooperation between countries, which made public health an area of bilateral cooperation. This analysis involved 22 sources. However, 75% of these were all press releases. We actually struggled to find primary sources. So I would like to invite everyone, so if you have primary sources, if we can get access to some of those documents from any of these meetings, I would really welcome that, as I'm looking to write a paper and collaborate with all of you on this. And of course, I will be attending and looking forward to the outcomes of the APEC policy dialogue to be held later this week. So, keen for that. Okay, so some preliminary insights from the analysis. Taiwan plays an outsized leadership and agenda-setting role for digital health diplomacy. It is a good example of niche diplomacy. It has advanced technical expertise in digital health, and health applications in conflict settings is an example of disaster diplomacy. Most global meetings in our analysis lacked evidence of direct collaboration between digital health stakeholders and their diplomatic counterparts. The only case where I've seen this, and this includes the global analysis of different regions, is Taiwan's co-location in Taipei of the APAMI, APEC, and AHIN meetings. And who would have thought, right, that you simply put people together in a room, get them to talk to each other, and lo and behold, they start coming up with really good ideas. So I think it's time to start breaking down silos and start having people interact with each other and across different sectors. And this digital health diplomacy is a good example of that. It demonstrates a strategy to effectively facilitate digital health diplomacy for the co-creation of policy and strategy, as we've already seen, but I think also cooperative technical outputs. And I saw this specifically in the example of AHIN's Community of Interoperability Labs. My colleague, Dr. Boonchai, will be speaking about this later on today. Pulling some of this together into higher level thinking. This is from a digital health maturity meta model. It's from a book that myself and my supervisor are currently writing. And it's on global digital health maturity. So thinking about how diplomacy itself can mature in a progressive and incremental fashion. Those 7 components are collapsed along the left. And across the top, you can see in the green bit, the 3 main maturity stages that diplomacy can take as it progresses. You start off with knowledge sharing and transfer. And we already know that's what Taiwan is doing in a big way, both within the region and outside of the region. I think we need to have an agreed global standard on speaking now about standards and interoperability, right? If everyone can agree that we set an open standard and work towards that and achieve that, we will all, as a globe, get to a point where all health data can become interoperable, and safely so. Now, this is an aspirational thing to say, but hopefully not too controversial. And it will take some courage to agree on what that minimum standard is. I think something that's useful to discuss in this regard is the International Patient Summary. Some of you may have heard of this. It is essentially a minimum data set that is required for transferring health data, or a minimized electronic health record across borders. It is a theoretical entity that exists, but if you think about what is already required for sharing for the WHO's Global Health Certification Network, that is already a minimum data set. And so we have some agreement on that. And moving ahead to establish a standardized global electronic health record would not be too much of a push from that point. Okay, I'd like to take a second now to speak to different stakeholders from different perspectives. So this one is now talking about the 3 dimensions. We'll talk about the first dimension, diplomacy for digital health. What does that look like? So people work
digital health. And the AHIN also promote the promotion of how the country should build the health, digital health governance in the country. We working with Ministry of Health and government, private and public to how to use the digital health responsibly and securely. We build the foundation of the digital health governance and includes the equitable, ensuring that no one left behind on this. So the AHIN has been about a decade. The network created by WHO, and then they said, why don't you come together as the network working together? With the last decade, what we learned is that the countries are trying to get the health information system or the digital health to work to support the digital health system. And we found that the big gap is that the country are not invest and also working on what we call foundation. And what is mean by foundation, we call it the GAPS frameworks, which is about the governance of the digital health, the architecture of the digital health, and the people and the program management. And lastly is the standard and interoperability. Dr. Lee had shown that the Taiwanese has been going through all of these, feeling all of these gaps, especially about the architecture and standard and interoperability. And we, as a network, we develop a kind of the concept of why don't we come together, all the Ministry of ICT, Ministry of Health, Finance, and why don't you come with the international developing partner to work on digital health? At this time, everyone see the vision of the countries, and we produce the kind of with the Asia Development Bank, the toolkit we call the Digital Health Convergence Meeting Toolkit, talking about the methodology that how we can gathering people in the country and between the country to help each other on advance or develop the digital health. And this is the example that we work with country in Asia. We go to all of these with the international developing partner like the ADB, UNICEF, World Bank, WHO, whoever that would like to support the development of the digital health. And with this collaboration, we form friends. And now we have a very good friend with Taiwanese academe, and also like Professor Singh, that we come and visit the National Health Insurance Administration, learn a lot from the My Health Bank, Medicrown, and also Pharma Crown, something. And we are learning a lot from Taiwan and also the other countries. So this is the example of what we call convergent workshop that we do across the regions. The last thing is that we working with developing partner like fire training. We just last month, Taiwanese got the grant from the Ministry of Health to do they call the fire connectathon. And then we can get AHIN member country to come and learn to do the connectathon, right? In Taipei, I think last 2 months. And with this, we can help each other building capacities. So you can see that Professor Singh, that is 2017 that we visit the Taiwan CDC and also the National Health Insurance Administration. And this is just last 2 months. We do the workshop on standard and interoperability within in Taipei, the connectathon. So what is the Asia eHealth Information Network? Actually, we are like all of you. We are the people who are passionate and want to build the national health information system and digital health in our country. So we come together and we help each other. We are not compete because of you have the agenda in your country. You have to do what? But we know that if we share and we work together, we will going very fast. And thanks to Taiwanese, Taiwan that sharing a lot with this compared to another East Asian country. Taiwan is the country that share a lot on how we're going to build the national health information system. And we are the, like I said, we sharing knowledge, promote learning, and then we encourage country to fill the gaps, all of the 4 components that we identify. So this is just the mission that we create with our member. We starting in 2011 with 7 people from 6 countries. When we met similar in the conference like this one, and then we said, why don't we come together? And then we just expanding our kind of the getting people to work in the Ministry of Health, in the academe, and in the international developing partner. And right now, the member is around 15,000, and it's all over the world, mostly in Asia. And we also working with another network in another region, like the Helena is a network in Africa, and Rakansa is a network in Latin American. So we kind of the sister network that can exchange knowledge and working together. So in summary, what we have built in the last decade, we create trust because we are friends, and we always say that when we help friends, friends will help us. So we just working like most of our member, maybe all of our member is volunteer. So the network is the kind of the NGO, international NGO, but we don't get any revenue. But we volunteer because we want to work for the countries, and we want to work with our friends in another country. We share knowledge and we share resources that we can have. So to me, I think this is the living proof of what we call the health diplomacy. We can work together, collaborate, and cooperate to build the good thing for the health system. With that, thank you, and now happy to take the more questions later. Thank you very much.
Thank you very much to Dr. Bongchai. Would you please wait on the side for the panel discussion? 那接下来呢是我们最后的 panel 以及 Q&A 的时间哦。And thank you to our 4 speakers for their sharing in this session. Thank you for Dr. Auer for highlighting the importance of trust to multilateral cooperation. Dr. Jianzhang Li for showing us how an upgraded healthcare information system can really do here in Taiwan, for Dr. Godino for sharing his insightful observations into Taiwan's digital health diplomacy, and for Dr. Bongchai for using the Asia eHealth Information Network as an example for health Digiplomacy. 非常谢谢刚才4位讲者非常精彩的分享，有分享到多边合作，信任是关键。那同时呢，以及更加进一步整合以及升级的卫生资讯的系统，也可以带来相当多的好处。那同时呢，我们刚才后面的2位讲者呢，也用他们自身的研究以及亚洲电子健康网络协会呢，作为最佳的外交以及卫生外交、数位外交的这个实力哦。Okay, and now we'd like to invite once again the moderator and all 4 speakers to join us once again for the Q&A. 接下来呢，我们要再次有请我们这个阶段刚才的所有的主讲人以及我们的主持人石处长到台上来。We'd like to welcome back Director General Shi and also Dr. Clemens Martin Auer, Dr. Jianzhang Li, Dr. Miran Anthony Godino, Dr. Bongchai, Kijisana Yoting. Please take your seats on the stage, and over to our moderator, Director General Shi. 接下来把时间交给署长。
Thank you, Dr. Bongchai. I liked the last slide, the first sentence you mentioned, the heart of the health diplomacy is the collaboration. I think the collaboration have to build on the trust. So back to our first speaker, the Dr. Auer, to emphasize the trust and the respect is fundamental to build the health diplomacy. Okay. I think that our section is slightly over time, but I hope that to open the section to all of our audience. So have any comments of the questions to our any speakers of the share your insights.
Yes, any questions or comments?
Please.
Thank you so much for the wonderful presentations. I have a question. I have two questions. My first question relates to, because we talk about digital health diplomacy, and then our last sessions we also talked about diplomacy after the COVID-19. So my questions are for the panelists is, when we talk about digital health, because data is so important that fuels the digital system. And then because we talk about, in one of the presentation, Dr. Morrow, you talk about health data, which is very sensitive personal data. So there's a lot of, shall we say, political considerations in sharing health data across borders. And it's quite interesting when we place this in the context of global health diplomacy, because China and some countries, they use the term sovereignty to describe data sovereignties as a resistance to data sharing at the international level. So I was wondering whether the presenters have any thoughts on data sovereignty as opposed to data solidarities as being proposed by the European countries. So that was my first question. And my second question, I was wondering whether any of the presenters have any information on the global strategy on digital health. Because we know the current one is 2020 to 2025, which is by this next year, and the World Health Assembly just agreed that they're going to renew the strategy. So I was wondering whether any of the presenters have additional information to share on this. Thank you.
Okay, so your first question is about the health data governance, or such as including the privacy, security, and etc. So maybe Dr. Oder.
I think the mic is on. Oh, okay.
In my presentation, obviously, I talked about the use of digital tools in diplomacy, but I have a very strong opinion on your question too, because I was chairing the EHS network in the European Union, etc., etc. And I'm a veteran in legislation and regulation digital health issues in my country, but also in Europe. 10, 15 years ago, the most important part of legislating, regulating the use of health data was about privacy and data safety. And I remember I had this endless debates in my home country parliament. The only thing the parliamentarians were interested in building a digital infrastructure was, is the data safe? How can the misuse of data be prohibited? That was it. And we were forced to build systems which sometimes made it impossible to exchange data, health data, because they had to be so safe that nobody was able to share them and use them. I see, at least in Europe, with the new European Health Data Space Regulation, a big shift in paradigm. That it's not only about security, privacy, but it's also a patient's right that digital data is used and shared. So this is a wonderful shift in paradigm which makes all these people
who, especially you two guys, who are still working in exchanging data, life much easier. Because it's also coming from the patient's perspective that the digital data is meaningfully used, and that's wonderful.
Yep. Have any comments?
The group called that trying to pursue or introduce, they call the health data governance models. And they're drafting the health data model law to inform many countries. I think starting in Africa and Asia. I think the Europeans are so advanced on that. But in lower middle income country, this is the movement in the international organization like the called Transform Health, trying to push this with many countries. And they would like to propose this to the WHO. Then I'll answer the second question too. You're asking about the global digital plan or strategy 2022 and 2025. We work closely with Digital Health and Innovation Department, Dr. Alan Labix, the director, and with many developing partners, USAID, World Health, World Bank, ADB, or the African Development Bank, something like that. They will going to kind of the update those to create those 2020 to 2025. I think to get the consensus on that is not easy, like the health regulation, something like that. But that is another. That is the move. The work that is going on to creating those.
Thank you. Thank you, Dr. Bongkai. Have there any question? Maybe we have another one, please.
Thank you, moderator. And mine is not a question, but just a comment. Or maybe let me start by saying warm greetings from the Kingdom of Eswatini.
Yeah, I'm sorry, maybe you have to speak a little bit closer to the mic. Yes, thank you.
Okay. I was saying warm greetings from the Kingdom of Eswatini. I would like to thank Taiwan for the opportunity to engage, learn, and network. We really appreciate. And according to my understanding, if I'm right, from what we learned today, is that global health refers to the health of the population worldwide. And global health diplomacy is the intersection of public health and foreign affairs to address global health challenges effectively. And I hope I'm right. Eswatini has benefited a lot through collaboration with the Republic of China and Taiwan, through the embassy and Taiwan Medical Mission, ranging from different fields, including technical support, deployment of expertise, medical specialists from Taiwan, collaborating in NCDs, maternal and child health. The list is endless. We still have a lot to do, though, collectively, to address a number of areas that include antimicrobial resistance, pandemic preparedness, and a lot, including health digiplomacy that I learned today. But before I conclude, I would like to say one thing, that there is no health for all, no all for health, if the all excludes Taiwan. I thank you.
Thank you so much. We have a strong technological capability and the highly skilled healthcare professionals. So we are very strongly willing to share our experience and provide any assistance as you need. Thank you, your comment. So I think we only the last question, please.
And please let us know who you are. Thank you.
Okay. Hi, this is Iris from Taiwan. And I have been working at health economic and outcome research. So I have the opportunity to analyze Taiwan's well-known database, National Health Insurance Research Database, which cover over 99% of the Taiwanese. So this is a really good database. And now, this is the first time I hear Dr. Lee's presentation to know that in the future we will have a comprehensive electronic health record network. Then we can have more data to analyze, and we can disclose even more outcome research in the future. So my question would be, because we know that the data could benefit lots of people and lots of many patients, because we can do the research and know the real world data, whom could benefit from that. So actually the data could benefit a lot. Just like the presenters has mentioned, if now we have the trust, we have the mutual trust, we have the collaboration together, then whom can benefit from the data? So who can have the access? My question would be, who can have the access to those great data? So I want to hear from presenters' suggestions that, based on your experience, that you might suggest that whom can use the data or who can have the access, because in Taiwan now, our access is only limited to researchers or some doctors, but not for commercial use. But actually, we know that for the commercial side, their experience could also benefit for the use of the data. So my question would be, whom can actually would you suggest to have the access to data? Thank you.
Yeah, this is a great, but actually very difficult questions. Yeah, so I think we can get a national level data, but data currently are built in two ways. One, some kind of like the communicable diseases. It's kind of like the public health issues. So I think that every stakeholders should have access to this kind of data. And in another ways, we know that the data is the oil of the 21st centuries. So more and more countries, more and more institutions view the data as their important resources. And after the industrial use, they can create very high value applications. Yeah, so we should separate these two things to see who have the right to access. From my perspective, if the use of the data is for the public good, and they should have the knowledge, because the wrong interpretation of the data will actually do more harm than good. So for this kind of a purpose, for public good, I think that we should try to open to our data to more people, not only the academia, but also for the industry, for the people, the general public. But for those who want to use as a commercial interested, I think they have to set up certain kind of rewarding systems and certain kind of value evaluation systems to make it very meaningful use, and also foster in a good and the right direction of the data economies. Because if we make the data for wrong use, and not only for you will cause some biased information or misinformation, but also it is not sustainable, because the AI consume a lot of energies. Yeah, so that's my perspective. Yeah.
I could just add a quick comment, and this is of course secondhand, but one of the models that I have heard used in Europe, so maybe my European colleague will be able to comment, is the setting up of social enterprises that are community owned and operated, that essentially act as data biobanks, and they hold on to the data that, for the people that it belongs to. They anonymize it, they pseudonymize it, and then they basically sell that anonymized data to commercial entities who have an interest in using it for HEOR research to test, for example, pharmaceutical applications. So that's one way of going about it. And of course, they pay for that, and that money goes back to the business, which is run as a social enterprise. And so that money is then shared with the owners of that data, and they can choose to leave it within the business and allow it to feed and grow that. Or they can choose to, export their dividend and take it with them. But that makes sure that the value that is generated is returned to the people from who it came. That's just one model that I know that is being used.
I don't want to get into it into details here, but it's always good to make a distinction between primary use of health data and secondary use. Primary use is solely for the processes of treating a sick person, and that's the data between the patient and the healthcare provider. That's easy. That was a traditional thing which was always non-disputed in politics, at least in the Western world. It's more complicated with secondary use, what you're saying here. So, in Europe at least, we found now with the new regulation on the European health data space a mechanism. It's a regulatory mechanism, and it's a governance model that secondary use is possible. You would totally agree very quickly for medical science, it's important to have access to this health data. So it's more complicated than what you are referring to is a commercial use, or the commercial interest of the same data. So should we block the commercial data interest totally? No, but they have to follow rules. And what the European Union now tried, and this is in the implementation phase, to set up regulatory mechanisms which allows also a commercial interest in certain data, but according to public rules. That's the important thing, because it has to be anonymized, et cetera, all this, I don't want to get into details. But yes, it is important that there is a strong governance, because once again, these are data of patients, of citizens, and they're of public interest. And there's an interest, and the people have to have trust that nothing wrong happens with their data. That's important.
I can understand your question. Even currently, our national health insurance big data is very useful, but it still have some barrier to be overcome. In spite of the academic use. So I think that we still need some time to achieve the social consensus. And it is the trust building process. We can ensure that just we say the even health Digiplomacy is quite new. It's a quite new term. However, digital health become our daily life. So when we are talking about the digital health, the data is basic, but the privacy and the safety, security is critical. Is fundamental. So we routed the insurance of the privacy, safety, security I think that it will be fair. So the time is over time, so we have to close this section. But even regarding the new terminology, we maybe still the different the description. However, our vision is very clear. The goal is to enhance the health outcome in the region through the collaboration and the public trust. So thank you, our distinguished speakers and the whole audience. We will end this section. Thank you so much.
Thank you very much to our speakers. But before I let you go, we're going to present the certificates of appreciation. Yes, can I have all 5 of you come to the front? Next, Director General Shi will be presenting the certificates of appreciation to our speakers on behalf of the organizer. Firstly, to Dr. Clemens Martin Auer. Yes. Yes, thank you so much. Let's have a photo. And next to Dr. All right. And next to Dr. Jianzhang Li. Thank you. Thank you. And next to Dr. Mira Anthony Godino. Thank you so much. And Dr. Bongchai, his son, Noyotin. All right, let's have a photo. Yeah, finally, can I have all 5 of you of the panel to have another group photo on the stage? Yes? Thank you. 最后我们再请这个场次的所有讲者一起合照一下。Okay, thank you once again. And thank you, everybody. That's a day 1 for 2024 Global Health and Welfare Forum in Taiwan. And thank you so much for your participation. And feel free to scan the QR code. You'll find the QR code in the back of your badge. Scan the QR code and fill out the questionnaire for the first day for us. Thank you again. And we'll see you tomorrow at 9:30 in the morning. 各位贵宾，那我们今天第1天的论坛呢，就到这边告一段落。都欢迎大家可以扫描 QR code 哦，帮我们填写第1天的问卷。那也提醒有借口译设备的贵宾呢，请记得归还。明天第2天的大会呢，是上午9点半，9点半会准时开始。We'll see you tomorrow and have a great evening, everybody. Thank you.